So today we are gonna do our chapter, that is neuroanatomy. Neuroanatomy is a very sweet chapter, but you have to just understand the things. The structures they are being less. You will feel blind. You can't visualize the structures because the structures are very small, and you can't just go on relating with this. But I will try to make the chapter sweet and as sweet as possible. Okay, I hope you will understand this chapter well. Let's talk about your neuroanatomy. So neuroanatomy, as I go on, you have to just retain the concepts as and when I move on. Okay, so let's talk about the general neuroanatomy. Formation of the neural tube. How the neural tube is formed. Neural tube is like the nervous system. It originates from neural ectoderm, and this has the neural tube, neural crest cells, and the ectodermal placodes. This neural tube is basically giving rise to your CNS. Neural crest cells are forming a PNS, peripheral nervous system, and this ectodermal placodes are giving your cranial sensory ganglia, your hypophysis, and your inner ear. Okay, process of formation of neural tube is called the nerulation. How it occurs? This is ectoderm, mesoderm, and endoderm, and you have a notochord here. So in ectoderm there is a thickening, ectodermal thickening is called a neural plate. This neural plate then regresses and form a neural fold, just a groove type of structure, neural groove, and this is called a neural fold. This groove then deepens. This groove will then deep, and the edges of this groove, the cells that are present at just the brim, is called as the neural crest cells. This neural crest cells will now detach, and this structure will be formed. Okay, so the neural tube here now. Understood? That completes this neural epithelial cells which get incorporated within the surface ectoderm are called as the ectodermal placodes. What is the clinical encephaly? Encephaly is the craniorheschisis. Okay, it is called the craniorheschisis. The failure of cephalic part of neural tube to close. And the failure of cephalic part of neural tube. Neural tube has a caudal part and cephalic part. So if there is the incomplete closure of a caudal neuropore, it is called as only rheschisis. That is your bifida, spina bifida type. Okay, and if there is the failure of cephalic part, which is called the craniorheschisis, and also there is defective development of vault of the skull. Features will that the vault of the skull is absent. There is no cervical vault. The head is absent, like the cranium is absent, and exposed brain is exposed here. Prominent eyes will bulge forward. Diagnosis is by ultrasonography, or alpha fetoprotein will be increased. There is no neck. The chin continues with the chest. Rheschisis is the severe form of spina bifida. In this, incomplete closure of caudal neuropore and defective development of vertebral that arches, due to which the neural tissue is widely exposed to the surface. Right. Quick facts: the nervous system and sense organ developed from neural ectoderm. Most primitive brain vesicle is the mesencephalon. We'll see about that. Process of neural tube formation is the nerulation. Most common fetal birth defect is the encephaly, which we talked about. All the circumventricular organs are related to the third ventricle except area postrema, fourth ventricle. We'll discuss about this also. Non-closure of anterior neuropore will lead to encephaly. Non-closure of posterior neuropore will lead to rheschisis. Cranial end of neural tube is called the lamina terminalis. Most simple spina bifida is the spina bifida occulta. Okay, and 7 windows of brain are your 7 circumventricular organs. Why is the encephalic fetus associated with hydrazaminos? Because there is no swelling reflex due to defective development of brain. So excessive accumulation of amniotic fluid will occur. This amniotic fluid will accumulate in excessive amount, that is 1500 to 2000 ml, and it will be related to hydrazaminos, that is your fluid accumulation in the brain. Development of vesicles, let's see. We have the neural tube here. We have the neural tube. Then formation of primary brain vesicles occur. The prosencephalon, the mesencephalon, and the rhombencephalon will form. This prosencephalon again goes on to form a telencephalon and diencephalon. Mesencephalon again goes on to form your mesencephalon. Okay, it remains the same. And rhombencephalon divides into metencephalon and your myelencephalon, right? These are your secondary brain vesicles. What are the structures they are giving? Let's see them. So this part, that is a telencephalon, it is giving a cerebrum and a corpus striatum. Okay. Then the diencephalon, telencephalon is giving a cerebrum and corpus striatum. Diencephalon is giving a thalamus, hypothalamus, metathalamus, epithalamus, subthalamus, optic stalk, and a neurohypophysis. Okay, these are all structures. These are given by the diencephalon. Your mesencephalon is giving a midbrain, metencephalon is giving a pons and cerebellum, and myelencephalon giving a medulla oblongata, right? You can say midbrain, pons, and medulla. And metencephalon, just remember another one, that is cerebellum. Okay. And what are the cavities that are giving rise? The cavity of the telencephalon gives rise to the lateral ventricle. The cavity of telencephalon, lateral ventricle. The cavity of diencephalon, third ventricle, and the cavity of metencephalon is giving the fourth ventricle, right? And the cavity of mesencephalon gives rise to aqueduct of Sylvius. Okay, so all cavities are giving rise to somewhat or other. Okay, except your myelencephalon. This myelencephalon is not giving rise to any other thing. Okay, any other that ventricle also. Let's talk about the blood-brain barrier. So there are three components. Your foot process of astrocytes. Astrocytes are specialized neuroglia cells which are present, and the foot processes of astrocytes are basically contributing to a blood-brain barrier. Then we have the basement membrane of capillary endothelium, and third is the tight junctions or zona occludens between your capillary and your endothelium. That is called a true blood-brain barrier. If this is present, this tight junction is called as a true blood-brain barrier. Okay. What are the areas devoid of blood-brain barrier? These are called as circumventricular organs, the CVOs. Okay, so what we have your area postrema, pineal gland, your neurohypophysis, subfornical organs, median eminence, and OVLT. Okay, area postrema, pineal gland, neurohypophysis, subfornical organs, median eminence, and your OVLT. Understood? So these are your circumventricular organs. You can remember the circumventricular organs by this mnemonic. Okay, you can take this mnemonic arch. Just let me make the mnemonic here. आज फिर नहीं सोया मोहन. Okay, so this is the mnemonic. आज फिर नहीं सोया मोहन. This is the mnemonic for your circumventricular organs. So A is for your area postrema, P is for your pineal gland, N is for your neurohypophysis, S is for your subfornical organs, M is for your median eminence, and O is for your OVLT. That is your organum vasculosum lamina terminalis. Okay, आज फिर नहीं सोया मोहन. This is your circumventricular organs. These are your circumventricular organs. Talking about this, we have the areas devoid of pain fibers. Which are areas are devoid of pain fibers? Mnemonic is bedpack. Remember bedpack. So B is for the brain parenchyma, E is for the ependyma, D is for the dura mater, P is for pia mater, A is for arachnoid, C is for choroid plexus. So these areas are devoid of pain fiber. B is for the brain parenchyma. Okay, E is for the ependyma. D is for your dura mater. Which part of dura mater? The part of dura mater which neither covers any blood vessels nor forming dural venous sinuses is only devoid of pain fibers. If the dura mater covers the blood vessel or it is forming any dural venous sinus, so it has pain fibers. Okay, so bed, and P is again for your pia mater, A is your arachnoid mater, and C is choroid plexus. Let's talk about the arachnoid matter. So you can see the arachnoid villi. Arachnoid villi are there. Here arachnoid villi are there, which are extending into the dural venous sinuses. Okay, endosteal layer of the dural venous sinuses. So this arachnoid villi, these are basically, this villi are moving, which is causing a movement of your CSF. Okay, and your CSF is present here in the subarachnoid space. In this CSF is present. It's basically present in a subarachnoid space. Okay, subarachnoid space. And talking about this, we have the arachnoidal villi. If they get old or clustered, they form your arachnoidal granulations. Arachnoidal granulations, they are present most maximally along the superior sagittal sinuses. Okay, and in due course of time, they can form meningioma of arachnoid origin. Okay, they can form meningioma, the tumor of the meningioma. It's also seen during the superior sagittal sinus, because the arachnoid granulations are present maximally along superior sagittal sinus. Okay, so there will be more meningioma of arachnoid origin present in the superior sagittal sinus. There are large subarachnoid spaces which are called as subarachnoidal cisterns. So there are majorly 8 cisterns. Okay, 8 cisterns, which are your callosal cistern, your chiasmatic cistern, interpeduncular cistern, pontine cistern, cisterna magna, superior cistern, cisterna ambiens, and the sylvian cistern. So these are your subarachnoid cisterns. So to remember this, I can make a silly mnemonic like this. Let's say callos. Just I am writing the spelling of callos wrong, because we have to just denote a callosal cistern. Callos chocos is probably made up of sealed sweet corn. Okay, so no offense those who are liking callos chocos. Probably this is a very silly mnemonic, but I made it to remember your subarachnoid cisterns. So kalos chokos. Kalos means your callosal system. Okay, kalos means your callosal system. This one. Chokos is a chiasmatic system. Just the ch pronunciation is that chiasmatic system. I is the interpeduncular system. Probably is the pontine system. Okay. Mid is the cisterna magna. Is the cisterna magna. Mid is the cisterna magna, and made up of is to make it suitable. Sealed. What is sealed? Sealed is just seal. SYL. Sylvian system, and sweet is the superior system. Sweet. Okay, superior system, and corn is a cisterna. Sealed, sweet, and your corn, that's a cisterna ambiens. Cisterna ambiens. Corn is a cisterna ambiens. Cisterna ambiens. Okay. So this mnemonic, just remember this mnemonic. Kalos chokos is probably made up of sealed sweet corn. Of course, it is not made up of that. Okay. Just remember. Let's see diagrammatically what are the systems you can see. So basically this is the diagram to draw in your exam, and you can see the corpus callosum here. You can see the corpus callosum, and this callosal system is just present just above the corpus callosum like that, and your midbrain pons and medulla are there. Midbrain pons and medulla. So basically we have a space here, which is forming your system. Okay, and we have a pons, that is a pontine system again. Then we have foramen magnum, and the cisterna magna is present here, which is also called the cerebellomedullary system, present in cerebellum and the medulla oblongata. So basically this cisterna magna, the cerebellomedullary system, this is the largest system which is present by which the foramen magnum is related to the foramen magnum. Contents are your 9th and 11th nerve. Is closest to the foramen magnum, so it can be used for cisternal puncture. If you have to do cisternal puncture, you can easily insert the needle by the foramen magnum. Okay. Of course, cisternal puncture is a bit risky as you are entering the brain. So that is the thing. Contents will also have the 12th nerve. Okay, so I have read half, that is 9, 10, 11, 12, and the part of vertebral artery is also present, a part which is called the pica, the posterior inferior cerebellar artery. Will see in the blood supply of the brain. Okay, and superior system is present like this between the corpus callosum, between your cerebellum and this part. Okay, this midbrain pons medulla part. Okay, so superior system we have also called as the quadrigeminal system, shaped in quadrigeminal shape. Okay, contents are the colliculae, all the colliculae. Vein of Galen is the main content, and your CSF is also present in all the systems. Okay, then we have interpeduncular system, that is present within the peduncle, cerebral peduncles that are present in the midbrain. Okay, so we have the interpeduncular system also in this PCA, that is the PCA is the posterior cerebral artery, and your posterior communicating branch of a cerebral artery is present. Okay, the circle of Willis, it's some part of circle of Willis is present in the interpeduncular system. So I hope you understood all the systems. Okay, and pontine system, one content basilar artery. Done. Then we have a system as the Sylvian system. The middle cerebral artery is present in the Sylvian system. Talking about the meningocele, is a meninges bulge out of the defective ossification of skull bones. Okay, only the meninges will bulge out. And the meningoencephalocele, the meninges plus the brain tissue will also be bulging out. And the meningohydroencephalocele, your meninges will bulge out, brain tissue will bulge out, along with the part of a ventricular cavity, part. Okay, which will also bulge out of this defective ossified part. Let's talk about the cells, ependymal cells, ependymocytes. We have the choroid epithelial cells which secrete the CSF, and the tanycytes, the ependymal cells that are basically lining the floor of fourth ventricle, having long basal processes. These are called as tanycytes. Okay, tanycytes. Talking about the oligodendrocyte, the cluster of neurons of gray matter, and these are responsible for the myelination in CSF. Okay, we have the microglia, that is the smallest neuroglia cell, and is derived from a fetal monocytes. That's why we call it as mesodermal origin. Sometimes a question is asked in the PG entrances that microglia, which neuroglia cell are of mesodermal origin. So you have microglia, and this removes cell debris, wastes and pathogens. What is replacement gliosis? That following neuronal death, the astrocytes will fill the space occupied by neurons, which is called the replacement gliosis. Okay, and if there is a brain tumor that is arising from the astrocyte, we call it as glioblastoma multiforme, which is the most fatal brain tumor. Neural stem cells are also present in the lateral ventricle and your hippocampal gyrus. The neurons in neuroglian peripheral neural system, we have satellite cells and squam cells. Satellite cells surround the nerve fiber bodies and give support and nutrition to this. And the squam cells are basically forming a myelin sheath around the axons and PNS, and these are made up of lipid-rich fatty substances. Talking about the nerve, so basically a nerve trunk is surrounded by your epineurium. Epineurium is surrounding the nerve trunk, and we have fascicles, many fascicles of nerves present, and these fascicles are surrounded with the pink part, that's the perineurium, and these axons are present. Axons are being surrounded by your endoneurium. Okay. Nerve injuries, we have neurotmesis, we have exotmesis, and your neuropraxia. We know about this neurotmesis. In physiology, you have read nerve regeneration and all, Wallerian regeneration and the retrograde regeneration and all. Okay. So basically, neurotmesis in axon plus myelin sheath both are damaged. In exotmesis, axon damage is there, myelin sheath is present, and neuropraxia both are present. So neurotmesis is a severe form. Ganglia may be sensory ganglia or autonomic ganglia. Autonomic ganglia means parasympathetic or sympathetic. Most common disorder of PNS is the neuritis. Neuritis is a phenomenon occurs in symptoms. The symptoms of neuritis occur first in hands and feet, which are called as a globe and stocking paresthesia. Radiculopathy is due to compression of nerve roots, that is spondylosis and disc prolapse. This causes radiculopathy. I got many syndromes are there, right? Most common CNS neurotransmitter is the glutamate. Most common PNS neurotransmitter is the ACH. Typical synapse is exodendritic or exosomatic. Pain relieving neuropeptide in CNS are your enkephalins and endorphins. Okay. And Fraze syndrome, we know about the Fraze syndrome. Which toxin travels via endoneural transport is the tetanus toxin. So that completes your general neuroanatomy and important points which are there in general neuroanatomy. Let's move on to the next part, that is your spinal cord. Let's talk about the spinal cord's length is 45 cm in males and 42 to 43 cm in the females. Weight is about 30 to 35 gram. Extent from in neonates, it extends from C1 to L3, and in your adults it extends from C1 to lower border of L1. Okay, so it is shorter in your adults. That is a transpyloric plane, up to your transpyloric plane. Remember, lower border of L1 was called as a transpyloric plane. Yes. Growth of vertebral column is faster than that of the spinal cord. So you have a cervical enlargement. That is present in C3 to T2 region. Okay, and the lumbar enlargement is there, which is present in L1 to S3. So there are two main enlargements, and the cervical enlargement is basically innervating the upper limb muscles and girdles. This lumbar enlargement is basically innervating the lower limb muscles and your girdles. And from this lumbar enlargement, the conus medullaris part, there is a tapering part which is called the conus medullaris. Okay, and we have a high density of nerve which is arising from this lower part of your lumbar enlargement in conus medullaris, which is called as the cauda equina. Okay, and it is surrounded by this dura mater and arachnoid, and there is a terminal part also. There is a terminal part which is called the phylum terminal, and which is attached to the coccyx. Okay. So preferred site for lumbar puncture, sometimes it is asked, so it is L1 to S2 level, and it is mainly done between the L3 and L4 also. Okay, it can be done in L3 and L4, this is safest. Talking about the spinal cord diameter, so modifications, what are the modifications? So basically we have three modifications: your linea splendens, the phylum terminal, and ligamentum denticulatum. Okay, linea splendens, phylum terminal, and your ligamentum denticulatum. These are the three modifications of the spinal cord diameter. And basically this phylum terminal is having 15 cm length and divided into an internus part. This is the internus of the phylum terminal, and this is the externus part, which is 5 cm only. This internus is covered by the dura mater and arachnoid, but this externus is not covered by, this is only covered by your diameter. Okay. And what we have in your linea splendens, what is linea splendens? So it is a bright line of your white matter of diameter, the white line of your diameter that is filled inside the anterior median fissure. This is anterior median fissure, this is a posterior median fissure. So basically this linea splendens, the white diameter that is extending up to your anterior median fissure. Okay. Then talking about the ligamentum denticulatum. So basically, if this is the spinal cord, we have some ligaments extending like this. You can see here. You can see this ligaments. These are denticulate ligaments which are present. These are your denticulate ligaments. Okay, so making spine, giving a spiny appearance to the spinal cord. Okay, and these are only two in number, 1 and 2, and each has 21 pairs of projections. 21 projections are there in each pair. Okay, each pair. And this ligamentum denticulatum, this is basically important surgical landmark for transverse sectioning of the spinal cord. In cordotomy operations, there is an important surgical landmark for transverse sectioning. Understood? And Okay, that is the thing. Then transverse section of vertebral canal. So we have many things like dura mater, arachnoid, and pia mater. The spinal cord is there. This is subarachnoid space. It is filled with villi and spinal. It is also called as subarachnoid space, also called as spinal interthecal space. And this subarachnoid space is filled with the CSF. Okay, and arachnoid is there. Dura mater is there. Dura mater is single layered, not folded. Epidural space is present. Dura mater of your spinal cord is single layered, it's not folded, and epidural spaces are present. What is the sequence of structures pierced by a lumbar puncture needle? So we have these things. First structure is the supraspinous ligament. This is the supraspinous ligament, which is pierced first. Then an intraspinous ligament is also pierced. Then it's pierced. Intraspinous ligament. This interspinous. Sorry. So between this spinous processes of this vertebrae, the interspinous ligament, which is also pierced, and then your ligamentum flabum is pierced. This is ligamentum flabum. This is also pierced. Epidural space is pierced. Epidural space is pierced. Then we pierce your dura mater, which is outermost arachnoid, and not piercing the pia mater. Okay. So this outside to inside, these structures are being pierced by the lumbar puncture needle. Okay, and just retain this. So spinal segments. What is a spinal segment? The part of the spinal cord to which a pair of spinal nerves is attached is called a spinal segment. So we have 12 thoracic spinal segments and 5 lumbar, 5 sacral, and 1 coccygeal. So basically we have 31 spinal segments. What is cauda equina syndrome? This is due to compression of the cauda equina, like fractures. It may be caused in fractures like element paralysis, saddle septal anesthesia, and severe root pain, late urinary and bowel disease occur. Or the features, okay, element paralysis, and there will be saddle septal anesthesia, severe root pain, late urinary and bowel retention, and the sexual dysfunctions, which may be caused due to your cauda equina syndrome. That completes the spinal cord. Let's move on to the next part. Let's discuss about the ascending tracts of your spinal cord. So it is a very important topic, ascending tracts. Basically, you have to just remember all the ascending tracts and all. Basically, we have the tracts which are important. Okay, I will talk about the tracts which are important, like a dorsal column tract is important. Okay, and spinothalamic tract. This dorsal column and the spinothalamic tract are basically important tracts. Okay, the dorsal column tract and the spinothalamic tract, what fibers they are carrying, and the spinocerebellar tract is also somewhat important. Okay, we'll talk about this. Let's talk. So basically, what we have, you have your thalamus here. We have a thalamus here, and there are some levels of neurons. We have the first order, second order, third order neurons. So basically, when the DRG, the neuron is going inside the spinal cord, this is the first order neuron. And from the spinal cord, the neurons which will ascend up to the medulla are called as the second order neurons. Okay, second order neurons. These are second order neurons, and this second order neurons form lemniscus and relay into a thalamus. At the level of thalamus, the neurons that will arise, the radiations that will arise, which is called corona radiata, are your third order neurons, right? Third order neurons. What are the internal features of the spinal cord? So basically a dorsal horn, a lateral horn, and a ventral horn. DH, LH, and VH. Okay. So what are the nucleuses that are present in the gray matter? Let's talk about the gray matter of the spinal cord. Let's talk about the gray matter. Talking about the gray matter, we have the dorsal horn here, lateral horn here, and ventral horn here. So basically in the dorsal horn, we have a substantia gelatinosa, which is present along the entire length, SG, substantia gelatinosa. Okay, and here we have the nucleus proprius, which is also present along the entire length. Okay, and there is a nucleus dorsalis, which is present in this part. Okay, a bit medial we have the nucleus dorsalis, which is also at the Clark's column. It is present in the C8 to L3 segment only. Then we have the visceral afferent nucleus, VAN, visceral afferent nucleus, which is present from T1 to S2 and S2, S3, S4. Okay, these are present from T1 to L2, and from S2, S3, and S4. This is called the visceral afferent nucleus. Then in the lateral horn, we have another nucleus called the nucleus of lateral horn, or intermediate horn. This lateral horn is also called as the intermediate horn. So don't get like confused if it is lateral or intermediate. You try to relate and don't get confused. Nucleus of lateral horn. So we have our nucleus from T1 to L2 and S2 to S3. So we have T1 to L2, the sympathetic neurons, okay, neurons, and S2 to S3 is the parasympathetic neurons. Then we have your lateral nucleus here, bit laterally, lateral nucleus, then your intermediate nucleus present, and then your medial nucleus, lateral, intermediate, and the medial nucleus. Okay, This lateral nucleus is supplying your limb muscles. This lateral nucleus is going towards the limb muscles. Okay, limb muscles. This intermediate nucleus is basically giving a phrenic nucleus and a spinal accessory nucleus. Phrenic nucleus from C3 to C5 and a spinal accessory nucleus from C1 to C5. Okay, phrenic nucleus from C3 to C5 and spinal accessory nucleus from C1 to C5. Just you can like you know this phrenic nerve is originating from C3 to C5 and spinal nerve is originating spinal accessory from C1 to C5. Okay, so nucleus is at that level also. Okay, so it is intermediate nucleus present only in the cervical region of the spinal cord, not present along the entire length, right? And the medial nucleus, the M is for medial nucleus, so supplying the midline. L is for lateral nucleus, supplying the limb muscles, and M is for medial nucleus, supplying the midline muscles or your axial muscles, like your intercostal muscles, the abdominal muscles, and all. Let's discuss the dorsal horn nucleus. So we are basically discussing the nuclei of the dorsal horn. So 4 nuclei are there. The substantia gelatinosa, which are taking pain, temperature, and touch. Pain, temperature, touch. Nucleus proprius. Nucleus proprius was present like this. Nucleus proprius is present like this. Nucleus proprius is taking interneuron, spinal reflexes, and conscious proprioception. Proprioception. Just remember like this. Proprioception, conscious proprioception, not unconscious. Okay. And the interneurons, nucleus and the interneurons, just try to relate. Okay, the nucleus dorsalis is taking an unconscious proprioception. Okay, nucleus dorsalis is taking unconscious proprioception. This one, nucleus dorsalis. Then a visceral afferent nucleus is there, visceral afferent nucleus, which is taking visceral sensation. Very easy. Dorsal horn nuclei, very easy. Substantia gelatinosa, nucleus proprius, nucleus dorsalis, and visceral afferent nucleus. Let's talk about ascending tracts. Let's move on to your ascending tracts. So what are the tracts and where they are present on the spinal cord? So here we have, here in this part we have a fasciculus gracilis. Fasciculus gracilis is a fasciculus gracilis present, and here is a fasciculus cuneatus present. Fasciculus gracilis is the muscle of lower limb, so it is taking sensations. Which sensation? Your conscious proprioception, fine touch, pressure, vibration, stereognosis, all this from your lower limb. This is taking from sensations from your lower limb, right? And this fasciculus cuneatus, there is a fasciculus cuneatus here, which is taking your sensations from your upper limb, right? And here more laterally we have your dorsal spinocerebellar tract, dorsal spinocerebellar tract here, and ventral spinocerebellar tract here. Okay, dorsal and ventral spinocerebellar tracts. These are taking for your unconscious proprioception. These are for your unconscious proprioception. Okay. And then we have a lateral spinothalamic tract, LSTT, lateral spinothalamic tract. This is taking in pain and temperature. And then we have anterior spinothalamic tract, ASTT, anterior spinothalamic tract, which is taking crude touch and pressure. Okay. And then we have another tract here, which is called the post dorsolateral tract of Lister. Okay. So basically we have to discuss this tracts. Basically we have to discuss the dorsal column tract and your spinocerebellar tract, and dorsal column tract, and the spinothalamic tract. These 3 tracts majorly. Okay, dorsal column tract, your spinocerebellar tract, and your spinothalamic tract. So talking about the spinothalamic tract, what is the spinothalamic tract and how it's the ascending tract. Okay, so we will go up. We'll track the course upwards. Okay. So what happens is that pain, temperature, crude touch, and pressure. Main thing is the pain and temperature, which is taken by the LSTT and the spinal lemniscus. Okay, pain and temperature. Just pay attention to this. Just pay attention. First is the dorsal root ganglia, where the first order neurons will arise, and this will relay into a substantia gelatinosa. Remember, substantia gelatinosa here, substantia gelatinosa, which is taking pain, temperature, and touch. Pain, temperature, and touch. Okay, pain, temperature, and touch. It is relating with the substantia gelatinosa. From the substantia gelatinosa, the fibers will decussate. To the ASTT and the LSTT, to the anterior spinothalamic tract and to the lateral spinothalamic tract. There is a decussation. The second order, just a very important statement. The second order neurons originate at the point of decussation. Okay, so when the first order neuron becomes the second order neuron at the point of decussation, at the level of decussation. Okay, so here they decussate and become the second order neuron. Second order neuron will relay into your ASTT and your LSTT, right? And this will extend upwards this is which is more medially is called as a medial lemniscus, which will go, and here we have the spinal lemniscus that will pass your midbrain pons and medulla and will go to the thalamus. They will relay in the BPL nucleus of thalamus. We will try to correlate the BPL nucleus. Okay, BPL nucleus, understood? What is the function of BPL and BPM nucleus? You can remember by this mnemonic: BPL, your very painful limbs. You can remember like this: very painful limbs. So basically the VPL nucleus is taking the pain sensations from limbs, okay, from limbs. And your BPM is a very painful mouth. Okay, you can remember like this. And so this is taking pain sensations from mouth and face. So we'll see in the thalamic nuclei, we will to discuss the thalamic nuclei, BPL and BPM nuclei we'll discuss. Okay, so basically the medial lemniscus is extending upwards, the spinal lemniscus is ascending upwards. We'll see this medial and spinal lemniscus when we'll take the midbrain sections, the pontine sections and the medullary sections. Okay, we'll see. And here they relay into thalamus, the BPL nucleus. Okay, for the spinal thalamic tract, BPL nucleus, and the thalamic radiation, the third order neurons will reach your cerebral cortex. That is area 3, 1 and 2. That is your primary sensory cortex. Primary sensory cortex is the area 3, 1 and 2. They are reaching the cerebral cortex. So that's about your spinal thalamic tract. Let's move on to the next tract, that is your dorsal column tract. This is also called the dorsal column medial lemniscal pathway. From this level. Okay, let's see. So basically the sensation of first order neuron will arise from your DRG, and what sensation they are carrying? The conscious proprioception, vibration, fine touch, pressure, stereognosis. These are relaying into your fasciculus gracilis. And the fasciculus cuneatus. Okay, these are again the first order neurons are there. No decussation has occurred. Just note, we are discussing this side. Which side? We are discussing your left side, and there is even no discussion. You can consider this right side. Okay, you can consider right side, you can consider this left side. So there is no decussation now. No decussation at this level. They will extend upwards as fasciculus cuneatus and the fasciculus gracilis. Fasciculus cuneatus is present laterally. Okay, as this is the midline, it is present a bit laterally, and this is relaying into the nucleus cuneatus, and the fasciculus gracilis is relaying into a nucleus gracilis. At this level of medulla, they decussate. Means which order of neurons these green neurons are? These are your second order neurons. At which level they become? At the medullary level they become second order neuron. Okay, at the medullary level, at the point of decussation. Okay, they extend upwards as a medial lemniscus, and this second order neurons going into the thalamus. Which nucleus? Again the VPL nucleus, and this thalamic radiations are reaching a sensory cortex, that is 3, 1 and 2. Very easy. Yes. So there is this point, internal arcuate fibers. These are called the internal arcuate fibers. The crossing point is called the sensory decussation. We call this point where there is decussation is called the sensory decussation. Just a fact to remember. Okay. Let's talk about your spinocerebellar tract. It's a little bit complex. Just bear with me. Not much complex. It's just little bit complex than the former pathways. Okay. So discussing about this, we have the midbrain pons and medulla, superior cerebral peduncle, middle cerebral peduncle, and inferior cerebral peduncle. Okay, these are there. Okay, of the cerebellum. So we have the three cerebellar peduncles, SCP, MCP, and ICP. Okay, which are connecting to the midbrain pons and the medulla. Talking about the spinocerebellar tract, what are the things? So let's see. It is also an ascending tract. So let's discuss this. Basically, what happens is the DRG, this from the upper limb. Okay, we are discussing from the upper limb the neurons of the DRG. Okay, this first order neurons are coming. Relaying into fasciculus cuneatus. Okay, fasciculus cuneatus. This fasciculus cuneatus is ascending upwards. This is ascending upwards. Okay, and it's connecting with the accessory cuneate nucleus. At this level. Okay, which level is this? This is your midbrain. This is your pons, this is your medulla. Okay, and here I have drawn this diagram in a very extended format, and your SCP, MCP and ICP. This is your SCP, this is your MCP, and this is your ICP. SCP, this is SCP, this is your MCP, and this is your ICP. So basically at the level of the medulla, it is not decussating. You can see this is not decussating, and it combines with the ACN. ACN is your accessory cuneate nucleus. It combines with the ACN, accessory cuneate nucleus, and becomes your cuneo-cerebellar tract. Cuneo-cerebellar tract. So this is your cuneo-cerebellar tract. DRG, it comes fasciculus cuneatus relays into your ACN, that is the anterior cuneate nucleus, accessory cuneate nucleus, not anterior, and it again becomes your cuneo-cerebellar tract. Okay, done. Then what happens? Another thing which is there. Okay, another thing. So we have the DRG here, the unconscious proprioception. The unconscious proprioception is coming like this. First order neurons are there. Then there is it is arriving in the it is first like going here. Okay, it is first going here. Okay, and here it has two parts. It's a two types of paths which are there. First, it can go from here. Okay, this is a DSCT, that is a dorsal spinocerebellar tract. It can go like this, it can go like this, and here it doesn't decussate. Here. Okay, but there is a level of decussation. So these are the second order neurons only. Okay, and this DSCT dorsal spinocerebellar tract. This is present dorsally. It is going like this, and it's relaying into the ICP, okay, going to the ICP. And then we have another ventral spinocerebellar tract. So what happens? It is decussating. The VSCT is decussating and is reaching a VSCT, that is a ventral spinocerebellar tract region. Okay, it is extending, it is going upwards, like this, giving radiations to your midbrain, pons and medulla, and it is reaching a superior your SCP, that is your superior cerebellar peduncle. Done. So BSCT is decussating, DSCT is not decussating. And which nucleus is this at which they are terminating? This pathway is terminating. This one pathway, the pathway is level 1, that's terminating. It's a nucleus dorsalis. Okay, just remember there is no DSCT that is the dorsal spinocerebellar tract for your upper limbs. So for your upper limbs, which tract is there? Your cuneo-cerebellar tract. Okay, there is a cuneo-cerebellar tract which is present for your upper limb. For upper limb there is no DSCT, but there is DSCT as well as VSCT for your lower limbs. Okay, so cuneo-cerebellar tract is the replacement of DSCT. That's a dorsal spinocerebellar tract for your upper limbs. Okay, cuneo-cerebellar tract is the replacement of DSCT for your upper limbs. Very important statement. So that completes your ascending tracts. Let's move on to the next part. So guys, now let's come to the descending tracts. I hope you understood all the ascending tracts. I have explained very well. Okay, you can just go and if you didn't understood, you can just check out my explanation. I hope it was up to the point. And talking about the descending tracts, we have again the things which are arranged like this. Okay, which tract is important? Pyramidal tract is very important, and we have to discuss the clinicals of pyramidal tract, like your tabes dorsalis and your syringomelia and your brown sequard syndrome, which often comes as a question. Okay, so pyramidal tract, which is also called as the corticospinal tract, which has two parts: anterior corticospinal tract, which is uncrossed, and the lateral corticospinal tract, which is crossed. Okay, we'll see that fibers are crossed in a lateral corticospinal tract and uncrossed in an anterior corticospinal tract. We'll discuss. Okay, we'll discuss. So here is the reason for the anterior corticospinal tract. Here's the part. Okay, anterior corticospinal tract. This is for the anterior corticospinal tract, and here is the part for the lateral corticospinal tract. There is a part for your lateral corticospinal tract. There is a tract which is lying here, which is called as a rubrospinal tract. Okay, and it facilitates the flexors, and inhibit the extensors. Okay, so it is facilitating flexion, inhibiting the extension. Okay, and then we have in this horn, we have a lateral reticulospinal tract and your medial reticulospinal tract. Okay, lateral reticulospinal, medial reticulospinal tract. And then in this part we have your ventrally we have your vestibulospinal tract, and here again we have your tectospinal tract. So what are the tracts that are present? This is a lateral corticospinal tract, this is your anterior corticospinal tract, then we have the rubrospinal tract. We have two tracts, that is lateral reticulospinal, medial reticulospinal, and vestibulospinal tract is there, and your tectospinal tract is there. Okay, rubrospinal tract has the function of facilitating flexors and inhibiting the extensors, and this vestibulospinal tract, this is facilitate the extensors and inhibit the flexors, just opposite movement as your rubrospinal tract. So vestibulospinal tract and this rubrospinal tract, these are working antagonistically, and that is unconsciously controlling the balance and the posture of the body. The vestibulospinal tract is basically controlling posture of the body. Vestibulo, just can you relate with the vestibular apparatus? Yes, yes. Talking about the tectospinal tract, tectum means the midbrain. Okay, and midbrain is basically connected with your head eye movements, that is based on visual stimulus. Like you're following a car with your eye, like a car, you're looking out of the window and a car is running in the road, that is a Ferrari, and you are just like your gaze is not deviated from that car, like you are just looking at that, so and turning your neck so as to follow the car up to its maximum visuality point. Okay, so following a car with eye and turning head with it is a function of your tectospinal tract that coordinates movement of your head, neck and eyeball based on your visual stimulus. Lateral reticulospinal tract is the facilitatory influence on the skeletal muscles. It facilitates the skeletal muscles, and medial reticulospinal tract, it has inhibitory influence on your skeletal muscles. So lateral reticulospinal tract is giving positive, medial is the negative. Just remember this. Talking about the midbrain, we have the tectospinal tract. Tectospinal tract is present like this. There's a dorsal tegmental decussation. This part of the midbrain is called the tegmentum. This section of midbrain at the level of the superior colliculus. So you have the red nucleus present in that, like this, and we have a decussation. Which is called the dorsal tegmental decussation, which belongs to this tectospinal tract only. Okay, and this is the superior colliculus which is present, and substantia nigra. You know about the substantia nigra. Important clinical is that is if there is a problem, if there is a defect in your if there is loss of neurons, loss of dopaminergic neurons from this substantia nigra, there will be there is a decrease in dopamine, and this will lead to your Parkinson's disease, paralysis as it turns. Okay, and there is a ventral tegmental decussation here. Ventral tegmental decussation, the level of red nucleus. Okay, which is called which belongs to your retrospinal tract. This decussation belongs to your retrospinal tract. Understood? Then we have, let's discuss the pyramidal tract. Pyramidal tract is very important. It's very important. Frequently asked. It's very important. Pyramidal tract, also called as the corticospinal tract. Also called as the corticospinal tract. Okay, we have lateral and anterior. We'll see about that. So it begins in the primary motor cortex, that is the 4, Broadbent's area 4. From the pyramidal cells of Bates. Okay, pyramidal cells of Bates are present. So we have the motor cortex. These are descending tracts. So we're going up to down. Okay, towards to down. Okay, we're starting from the up. So motor cortex beginning in the pyramidal cells of Bates. Okay, and we have the posterior limb of which are going. The fibers are going. Okay, in the posterior limb of your internal capsule. Posterior limb of the internal capsule. These are reaching a midbrain. At the level of cerebral peduncles, reach the pons at basilar part of pons, and at the level of lower medulla oblongata is the level of your pyramidal decussation. Lower medulla oblongata, it decussates into, that's 85% of fibers. 85% of fibers are decussated fibers, that is forming a lateral corticospinal tract. 85% fibers decussate from here and form a lateral corticospinal tract, and rest 15%, this only don't decussate and go downwards just like this, and are forming your anterior corticospinal tract. 15% fibers are anterior corticospinal tract, and your 85% are your lateral corticospinal tract, right? This lateral corticospinal tract, this goes down and relays here, and from here element neuron, lower motor neuron will arise and supply your limb muscles, and this also anterior corticospinal tract, this 15% fibers, this also come here, again a decussation point, again a point of decussation here, and this again reach this part, element neurons will left. These are ending on the anterior horn cells. Okay, and also end on inhibitory interneurons that are part of a physiology. I'm not going into detail. So and these are ending in here, and the element lower motor neuron is reaching in midline and axial muscles. So basically this anterior corticospinal tract is supplying your midline or your axial muscles, and this lateral corticospinal tract, this is supplying your limb muscles. L for lateral, L for limb. Okay. Clinicals to discuss. We have a syringomelia. Syringomelia is a fluid-filled cavity develops near the central canal of spinal cord, usually in the cervical part, where this part, if fluid-filled cavity is there, so area affected is the decussating spinothalamic tract. Okay, the spinothalamic tract that was decussating here, that will be affected. The spinothalamic tract that was decussating in this region will be affected. If you can't understand, let's move on to the spinothalamic tract again and see how it is decussating. Let's go on. Just look at this. This is your spinothalamic tract. This is again a spinothalamic tract, and here was the point of decussation. Here all the decussations were occurring, in which the tract was forming LSTT and ASTT. Okay, this is the point of decussation. So if there is the defect here, if there will be the defect here, then what will occur? Your pain, temperature, crude touch and pressure, these all parts will affected, of which of your contralateral side, you know contralateral and ipsilateral concept, that is ipsilateral, the same side defect of this pain, temperature, crude touch, pressure, it will not occur. Your contralateral, like if this is affected, if this part is affected, then this pathway will not occur. Like this is you can say right side, and this is going to left side. So left, if there is a defect in this left decussating pathway, then there will be contralateral loss of your pain, temperature and your crude touch. Pain, temperature, pressure and your crude touch. Okay, I hope you understood. Now let's move on to, let's go back. Okay, let's go back and discuss what is syringomelia and all. So here there will be area affected decussating spinothalamic tract. Basically, if the central part is affected, if there is the lateral deviation, then there will be contralateral. But if the central part is affected, both tracts, the both spinothalamic tracts, these are basically affected. The both tracts are affected. So there will be bilateral loss. Actually, there will be bilateral loss of pain, temperature, crude touch and pressure below the level of lesion. Okay, understood? So basically this will be happening. Okay. And you can see your syringomelia, that is patient, the radiograph. Then there is a tabes dorsalis. It is a syphilic degeneration of posterior column and posterior nerve root. The tracts affected will be fasciculus gracilis and the fasciculus cuneatus. Will be affected. Remember this fasciculus gracilis and cuneatus, these were going up and forming your dorsal column pathway, dorsal column medial lemniscus pathway. So if this parts are affected, so there will be loss of conscious proprioception, that is ipsilateral loss of your conscious proprioception and ipsilateral loss of your fine touch, vibration and your stereognosis, right? You can just see here very well. I came back to your dorsal column tract. There is damage here, there is damage in this part, your fasciculus gracilis and the fasciculus cuneatus, these are mainly affected. Okay, these are mainly affected, and this were taking your conscious proprioception, a vibration, fine touch, pressure and the stereognosis. So there will be ipsilateral loss of this all. Like phenomena. Okay, there will be ipsilateral loss. Understood? So here loss of conscious proprioception ipsilaterally, and ipsilateral loss of fine touch, vibration and stereognosis. Sign is called the positive Romberg sign. The positive Romberg sign is basically used to diagnose this tabes dorsalis. So you can ask the patient to stand and close his eyes. The patient tends to fall towards the affected side. Like if the right column tract is degenerated, the patient will fall towards the right fall. There will be right fall of the patient. Okay. Let's talk about a Brown-Sequard syndrome. That's called a hemisection of the cord. Okay, so if the dorsal column tract here, which is affected, pyramidal tract affected, spinocerebellar tract affected, spinothalamic tract affected, all of these tracts are affected, means there is a total paralysis of this cord. Okay, so what are the things that are that will be affected? So let's see. The spinothalamic tract was affected. The spinothalamic tract was coming here and was decussating at this level. And so there will be contralateral loss of pain, temperature, pressure and crude touch below the level of your lesion. Okay, so basically we have the ipsilateral loss of pain, temperature, pressure at the level of lesion. Why? Because if there is the lesion, okay, this is your lesion. Okay, so basically at this part the lower tracts will be like going. Okay, so this part is also affected. Okay, and this pathway is going like this, in this manner. So at the level of lesion there is ipsilateral loss. If at the level of lesion, if there is lesion here at the level of lesion, there is only ipsilateral loss. But below the level of lesion, there is contralateral loss of pain, temperature, pressure. Okay, below the level of lesion, the contralateral loss is there. Talking about the dorsal column tract, you know about the fasciculus cuneatus and fasciculus gracilis. These are going like this. Okay, this point is affected. If this point is affected, there will be ipsilateral loss. Okay, below it there will be ipsilateral loss at the level of lesion. Okay, there will be ipsilateral loss at the level of lesion like this. But what will happen below also there will be ipsilateral loss, because there is no decussation at this level also. Decussation will be at higher levels. Okay, so that matters specifically. Talking about the spinocerebellar tract, this will be also affected. So what happens, this is the level of lesion, and from this your dorsal spinocerebellar tract is occurring. So there will be obviously ipsilateral loss of conscious proprioception at the level of lesion, as this spinocerebellar tract is taking in unconscious proprioception. So there will be same side only, ipsilateral loss of unconscious proprioception at level of lesion, and ipsilateral loss of unconscious proprioception below the level of lesion. Okay. Talking about the pyramidal tract, so what will happen? The pyramidal tract, there will be contralateral hemiplegia is common in pyramidal tract lesions, but here just pay attention. That pyramidal tract decussation is occurring at the upper level. Decussation will occur at the upper level. So there will be ipsilateral flaccid paralysis, because this point is affected. So there is ipsilateral flaccid paralysis at the level of lesion, but there will be ipsilateral spastic paralysis below the level of lesion. Ipsilateral spastic paralysis. Okay, so flaccid paralysis at the level of lesion and spastic paralysis below the level of lesion. So what are the effects of this tract? You can now just write Brown-Sequard syndrome. What are the effects? There will be contralateral loss of pain, temperature, pressure, and conscious pressure below the level of lesion. Ipsilateral loss of pain, temperature, to touch, pressure at the level of lesion. Due to the effect of the dorsal column tract, there will be ipsilateral loss of conscious proprioception, vibration, fine touch at the level of lesion as well as below the level of lesion. Okay, and due to involvement of spinocerebellar tract, the unconscious proprioception will be affected below and at the level of lesion, and there will be pyramidal tract involvement. There will be flaccid paralysis as well as spastic paralysis at and the below. The flaccid paralysis will be at the level of lesion and spastic paralysis below the level of lesion. Okay, so that is the whole concept of your Brown-Sequard syndrome. Let's move on to the next part. Our next parts. Now guys, let's talk about the brainstem. Talking about the brainstem, you can just observe the brainstem here. Okay, you can just observe the brainstem here. So here is your olfactory tract. This is olfactory tract. This is olfactory bulb. There is an interpeduncular fossa between the two peduncles of the brainstem. That you have the interpeduncular fossa. You have the cerebral peduncles here, and this fossa is between your cerebral peduncles, right? And we have a basilar sulcus. This is a basilar sulcus, and we have a medulla oblongata. This is a medulla oblongata. This is your brainstem. Talking about the ventral aspect of the brainstem, this is the ventral aspect of the brainstem. This is a ventral aspect. You can just practice drawing this diagram, and then we'll see about the interpeduncular fossa also. Okay, and we'll then go to your dorsal aspect of the brainstem. So talking about this, this ventral aspect and dorsal aspect are very important. Just pay attention to this. So we have the cerebral peduncles. These are not cerebellar, cerebral peduncles, which are present in the midbrain. One cerebral peduncle is like this, one cerebral peduncle is like this. Okay, and from the interpeduncular fossa, a third nerve arises, and your fourth nerve is arising like this. The third nerve and fourth nerve you can see here. Then we have the pons. This orange part is the pons. This is your pons. This whole part. Okay, and here we have the sulcus in middle. That is called as the basilar sulcus. And below the pons we have the olives. Here. Okay, we have the olives here, and the pyramids. Olives and the pyramids, which are a part of your medulla. Okay, medulla. So what we have your midbrain, pons, and the medulla. Okay, midbrain, pons, and the medulla, which we can see here. And in this pontine part, the sixth nerve arises, seventh nerve with its thick sensory root and the thin motor root, this eighth nerve, and the fifth nerve also, okay, it arises from these parts. And from the olive part, your ninth nerve arises, 10th nerve arises, your 11th nerve arises, your 11th nerve also arises. And 11th nerve also part, the 11th nerve, remember the cranial nerve, the cranial part was there, and your spinal part was there, right? Your cranial accessory and spinal accessory. So this is the cranial accessory now which is arising, and the spinal part will arise from a C1 to C5 segments, right? This is coming from behind, inferiorly, and is arising here, 11th nerve. So you have in sequence like 3, 4, then you have the 5, 6, 7, 8, 9, 10, 11, right? And these nerves are arising lateral to the olive, and this 12th nerve, you can have a 12th nerve also, 12th nerve which is arising between your pyramid and the olive. This is your pyramids, and here is the olive. So this is arising between your pyramid and the olive, right? So this is your ventral aspect of your brainstem, right? So 6th nerve arises from the pontopyramidal junction. You can see pontopyramidal junction is giving rise, this pontopyramidal junction is giving rise to 6th nerve. 7th nerve from ponto-olivary junction. The 7th nerve is arising from the ponto-olivary junction. You can see olive and the pons. And this 8th nerve from the pontomedullary junction. 8th nerve from the pontomedullary junction. You can see medulla and this part. Okay. Let's talk about the interpeduncular fossa. This fossa we will talk about. We talk about this fossa. We'll talk about this fossa. So here we have the boundaries of the interpeduncular fossa. So here we have the interpeduncular fossa. Let's take some other color so as to avoid confusions. Let's take green. Yes. So here we have the optic tract. Here's the optic tract. There's a crossing optic chiasma, and the optic nerve. Optic nerve will be there. This optic nerve, you know about all this. Lateral geniculate body is there. Then what are the heminopias? What are the bitemporal heminopia and all? Okay, this above will be that part. Okay, this is your olfactory bulb here, olfactory tract, and which is dividing into two parts. And between them we have your anterior perforating substance. Okay. And in this boundaries, what are the boundaries of this interpeduncular fossa? So the superior boundaries from the optic chiasma. This is optic chiasma from the superior boundary, and optic tract and the optic chiasma is on the superior boundary. Then the cerebral peduncles are bounding is laterally. Okay, the lateral boundaries are from the cerebral peduncles of this midbrain, and the pons is forming your base. Okay, base. What are the contents? The one is your infundibulum pituitary gland, which is present in this part, infundibulum pituitary gland. 2 is in mammillary bodies. 2 mammillary bodies are present at this interpeduncular fossa. Then the third nerve is arising here. Third nerve will arise like this. We have seen the third nerve being arising like this. Just see. So third nerve is obviously a content of your interpeduncular fossa. We have also learned this in the third nerve. Okay. I can check head and neck lecture. Then fourth is a posterior perforating substance. Okay. So here we have the real-time section. You can observe the real-time section if you want. And talking about the relations of the anterior perforating substance, we have the anterior perforating substance here. What are the relations? So the medial relation is the optic chiasma. Lateral is the lamin insulae, and posterior is the optic tract. Okay, posterior is the optic tract. This part, posterior is the your optic tract. Is here. Okay, this is the posterior relation, and you can easily write your lateral relation, that is your optic that olfactory nerve in the olfactory tract. Okay, the medial relation is the optic chiasma, and lateral relation the lamin insulae. Okay, so these are the parts. Talking about the dorsal aspect of brainstem, it is present on the floor of the fourth ventricle, that is your rhomboid fossa. This is your dorsal aspect of the brainstem. You have a pineal gland that is present here. You have the fourth nerve that is arising from here. Okay, and it is moving front. Okay, and then we have another one, that is your facial colliculi, the 2 facial colliculi, and middle cerebral peduncle, your superior middle, and the inferior peduncles. Okay, you can see the peduncles here, and median eminence is there. There is a median eminence here, and the fourth ventricle, rhomboid fossa. So talking about this is the whole structure. You must have practiced this structure many times so as to bring that reflex in drawing the structure if the brainstem is asked. So if the superior colliculi here, the inferior colliculi here, okay, which is called the corpora quadrigemina. In your lower animals, in your snakes and all, corpora bigemina is present. Okay, so you have the fourth nerve that is arising from this part. Fourth nerve which is arising. Fourth nerve is also seen in this ventral aspect. In this ventral aspect, this fourth nerve will be arising and coming to the front like this. Okay, it will be winding around like this. So we have the fourth nerve that is winding around like this. We have the superior cerebral peduncle. We have this middle cerebral peduncle and this inferior cerebral peduncle. Okay, so these are the things. And we have a superior fovea. There is a superior fovea here. These two parts, black parts, superior fovea present, and there is a sulcus. It's called as a sulcus limitans. This is a sulcus limitans here and a sulcus limitans here. Two sulcus limitans. This is a vestibular triangle that is formed. This green one is a vestibular triangle that has been formed. This is a vestibular triangle, and this is a facial colliculus. These orange balls are the facial colliculus. And this triangle which is formed here is called the hypoglossal triangle. Okay, and we have the bands. We have a the tendinous bands, stria medullaris. Okay, and a vagal triangle is also there. And we have the area postrema, which is also called the CTZ, chemoreceptor trigger zone. Remember, we talked about the areas devoid of your it is a circumventricular organ devoid of blood-brain barrier, called the vomit center, right? And this part, this point is called the obex is this point. Okay, and this we have the inferior fovea. We have the superior fovea, right? We have the superior fovea here, and the inferior fovea here, which are being connected. It's being connected to the vagal triangle, right? And we have a gracile tubercle. This is a gracile tubercle, which are present. These were your pyramids, and posterior to this pyramids are your gracile tubercle. Because we are seeing the dorsal aspect, right? We are seeing the dorsal aspect. Okay. So in facial colliculus, these are the resultant of neurobiotaxis, a phenomenon. It is the migration of motor seventh nucleus will be occurring towards the sensory fifth nucleus for faster reflexes, and this will cause the creation of this facial colliculus. Okay, facial colliculus. And obex, what is obex? So you saw here obex. This was obex. Obex is a thin sheet of white matter stretching between the gracile tubercles. You can easily see your gracile tubercles being here. So this is obex is a thin band of white matter that is stretching between the gracile tubercles. And the inferior angle of fourth ventricle looks like a nib of a pen, so it is called the calamus scriptorius. This is just a term. Okay, calamus scriptorius is nothing but an inferior angle of your fourth ventricle. So basically you can see the fourth ventricle here, and it is stretching like a nib of a pen, this part. So it is called the calamus scriptorius. Done. So this is the brainstem, dorsal and the ventral aspects of the brainstem. Let's move on to the next part. So basically we are into the very important part of this chapter. Very frequently the brainstem sections are asked, and you have to practice drawing this. We'll use this table also. Just let me explain you the table. Okay, what are the things that are given here? Let me explain you first. Let us go to a detailed part of this lecture. Okay, the detailed part of this table, because I haven't taught this table in your head and neck. So let me finish that first. So let us learn about the cranial nerve nuclei and the columns first. So first is 1 is the olfactory nerve, 2 is the optic nerve, 3rd is the oculomotor, 4th is the trochlear, 5th is the trigeminal nerve, 6th is the abducens nerve, 7th is the facial nerve, 8th is the vestibulocochlear, 9th is the glossopharyngeal, 10th is the vagus, 11th is the spinal accessory, cranial accessory parts, and 12th is the hypoglossal nerve, right? Cranial nerve nuclei. So ganglion is a collection of nerve bodies outside the CNS, while nuclei is a collection of nerve bodies inside the CNS, right? So pharyngeal arches, from this pharyngeal arches, this nerves are generally originating. We'll see about that. We'll read about that in your pharyngeal arches in your embryology section, not now. So this is a neural tube. So you have a alar plate, which is your sensory plate, which will give rise to all your sensory cranial nerve nuclei, and the basal plate is a motor plate, and it will give rise to all the motor cranial nerve nuclei. Okay, this in the due course of development. Okay, this space will give rise to fourth ventricle, and in this due course of development, this will form like this, something like this. There will be sulcus limitans. This is a sulcus limitans. This is a sulcus limitans, and this is a fourth ventricle. This red part is the Eller plate, this blue part is the basal plate, right? And we have the GSC column, SVE column, and GVE column here, GSC, SVE, and GVE. And here we have the 4 columns, that is GVA, SVA, GSA, SSA. GVA, SVA, GSA, SSA. Okay, and here we have GVE, SVE, and GSC, SVE, and GVE. Okay, so GS again combine GV. Okay, G and V, G and V combine. Then we have a GVA, SVA. Okay, G is the first one, and GVA, SVA, and after that GSA, SSA. Okay, this you can make some trick or so to retain this thing, otherwise you may get confused in locations and all. So GSC means general somatic efferent, which will supply, which will give rise to your oculomotor nerve, trochlear nerve, abducens nerve, and hypoglossal nerve. Basically, just somatic, okay, general somatic efferents, so general sensations. And somatic nerve means extraocular muscles and the tongue muscles. Okay, basically this all nerves are supplying this all. Okay, the tongue and the extraocular muscles. And SVE means spatial visceral efferent column or branchial efferent column, which are supplying the muscles derived from the pharyngeal arches. Pharyngeal arches are, what are the muscles derived from the pharyngeal arches? We have the muscles of mastication, muscles of facial expression, stylopharyngeus, muscles of palate, pharynx, larynx, all this developed from your pharyngeal arches. So this SVE column is gonna supply all the muscles derived from pharyngeal arches. GVE is a general visceral efferent, those supply the smooth muscles and the glands. GVA is the general visceral afferent column. So it will carry general sensations from the viscera, like touch, pressure, temperature, pain. Then SVA is the special visceral afferent, special sensation. So what is the special sensation? Only special sensation from viscera is the taste. Okay, so SVA column only taste. And the GSA column general somatic afferent, will carry general sensation, that is the pain, temperature, pressure, and this all general touch, pressure, temperature, distance, and all this from somatic, or from the sensation coming from somatic. This is the body wall. Okay, body wall. And then we have a special somatic afferent. So special sensations, that is your vision, taste, balancing, olfaction from a somatic organ. Special sensation from a somatic organs mean olfaction, vision, hearing, and balancing. Okay, this all. And for olfaction and vision, we don't have any nuclei, but for hearing and balancing, we have our eighth nerve is your auditory nerve, or your vestibulocochlear nerve. Let's talk about what nerves are present, which nuclei are present in what columns, in what regions. So first let's discuss the GSC. So we'll discuss the GSC. Midbrain. In midbrain, the GSC of the third and the fourth. In the pons we have the 6th, and the medulla oblongata we will have the 12th. Okay, third, fourth in the midbrain part. GSC column, third, fourth, midbrain part. Pons we have the 6th, and medulla oblongata we have the 12th. Okay, 3, 4, 6, 12. In the SVE column, we don't have any in the midbrain, but in the pons we have the V3, and the 7. Okay, the V3, that is mandibular nerve, and your 7th nerve nucleus. V3 and the 7th nerve nucleus in the pons. Okay, and in the medulla oblongata we have the nucleus ambiguus in the SVE column. The nucleus ambiguus, that is 9, 10, 11. The nucleus of 9, 10, 11 if used are called as nucleus ambiguous. Okay, so the origin of the 9, 10, 11 nerves is from the medulla oblongata. 9, 10, 11 of medulla oblongata, that is also from a nucleus ambiguous, right? And GVE column, your GSC is done, SVE done, then GVE column, it in midbrain we will see the Edinger-Westphal nucleus. In the pons we will see SSN and ISN, that is a superior salivatory nucleus and an inferior salivatory nucleus. Okay, we have discussed this nucleus in your secretomotor pathways of your parotid gland, as well as the sublingual and submandibular glands. Okay, you can check out the head and neck lectures. And in the medulla oblongata we have the dorsal nucleus of vagus. Okay, dorsal nucleus of vagus. And the nucleus of vagus from medulla also, and we have the nucleus of vagus from SVE as well as from GVE. Okay, the dorsal nucleus of vagus. Understood? So GSC column, just try to close your eyes and memorize with me. So GSC column, in the midbrain we have the third nucleus and the fourth nucleus. Okay, so 3, 4. Then in the midbrain pons, in the pons part we have the 6th. Okay, 3, 4, 6, and we have the 12 also in the later part, that is medulla oblongata. Okay, SVE column, So there is no nucleus present in the midbrain. In the pons part, we have the V3 and 7. Okay, V3 and 7. V3 means your mandibular nerve, and seventh is your which nerve? Seventh is which nerve? Do comment. Okay. Then medulla oblongata. In the medulla oblongata part of your GVE column, SVE column, we have the nucleus ambiguous. 9, 10, 11 nucleus ambiguous. Okay. And talking about the GVE column, we have the Edinger-Westphal nucleus, which is present in the upper part. What is the upper part? That is the midbrain. In the pons, there are two nucleus, that is SSN and ISN. Okay. And in the later part, that is medulla oblongata, we have only one nucleus, that is dorsal nucleus of vagus. Done. These parts are done. You memorized all this. Let's go ahead. So this in 12th nucleus, okay, nucleus of 12th nerve and nucleus ambiguous. If this is injured, if the 12th nucleus, this one, and the nucleus ambiguous, this part is injured, this columns are cut. Okay, GSE and SVE means here, or GSE and SVE, this part is, if this part is injured, there will be a special feature that is called ipsilateral bulbar paralysis and loss of gag reflex. Okay, loss of gag reflex. This gag reflex is controlled by 9th and 10th nerves, obviously. So these are cut. And talking about the GV column, a parasympathetic column, we have the Edinger-Westphal nucleus. This is via your third nerve. This Edinger-Westphal nucleus, via the third nerve, it supplies the sphincter pupillae and ciliaris muscle. Remember, the superior salivatory nucleus via the 7th nerve will supply submandibular, sublingual, lacrimal gland. Remember, in head and neck, yes. Inferior salivatory nucleus via 9th nerve will supply your parotid gland. This also you remember. Okay, via 9th nerve. Then that is your auriculotemporal nerve branch was going, and secretomotor pathway of parotid gland you can just refer. As dorsal nucleus of vagus by the 10th nerve. The 10th nerve is supplying the smooth muscles of glands and thoracic and abdominal viscera. Okay. So this 3, 7, 9, 10, these are called as the parasympathetic cranial nerves. Which nerve form parasympathetic outflow or craniosacral outflow? These are your 3, 7, 9, 10 and S2 to S4. This you have read in ANS chapter of your physiology. Talking about the GVA column, GSA column and SSA column, GVA, GSA and SSA. So in the midbrain and pons, there is no nucleus. In GVA and SVA column. In the GVA column. Okay, just you remember GVA. Okay, GVA. Otherwise, you will get confused. The GVA, and then we'll talk about your GSA. Okay. So in the GVA column, we have no nucleus in the midbrain and pons, but there is a nucleus in the medulla, which is called the nucleus of tractus solitarius, which is the SVA part and the GVA part. SVA part and the GVA part. The special visceral afferent and the general visceral afferent, right? So for your GVA and SVA, okay, so basically we have only one nucleus present in medulla, that is the nucleus of tractus solitarius. Okay, nucleus of tractus solitarius. And in your GSA column, just try to memorize with me. In the GVA and SVA, only one nucleus, that is in the medulla oblongata, that is the nucleus of tractus solitarius. Okay, which is a small SVA part and a large GVA part. Okay. And the GSA column, in the GSA column, we have one nucleus, that is a nucleus of trigeminal nerve, huge nucleus of trigeminal nerve, which will extend from midbrain to pons to medulla. Okay, which will extend from midbrain to pons to medulla. Okay, it's a huge nucleus. So this nucleus is there many parts. It's called as your it has a upper part that's called mesencephalic nucleus, which will do the proprioception, which will be responsible for the proprioception. Then the principal nucleus, dilated part of the principal nucleus or chief sensory nucleus. Okay, which will do touch and pressure. So proprioception, mesencephalic nucleus, and touch and pressure, chief sensory nucleus, and your spinal nucleus. This spinal nucleus, this later part will be for your pain and temperature, right? So it will extend up to the C2 level. This is your trigeminal nucleus. And in the SSA column, there will be no nucleus in the midbrain as well as in the medulla. There is a nucleus in the pons, which is called the vestibulocochlear nucleus. So the shape is like that, like this. You will draw an arrangement: vestibular nucleus and two cochlear nucleus. One vestibular nucleus and two cochlear nucleus are present in the pons. That is your SSA, right? SSA. So we told that for your that balance and equilibrium and balance, we have this for your vision and your olfaction. We don't have any that nucleus present. Okay. So if you just understood all the cranial nuclei, the columns and all, so let's go back to our neuroanatomy and let's try to correlate these things. So these things I taught here because it will be better if you can correlate these things in the brainstem sections. Okay, you'll remember these things and in your brainstem sections. So getting into the brainstem sections, we'll use this table has all the components which are there in your brainstem section. When we'll have doubt in any of the parts, we'll refer this table for more details. Okay, so let's talk about all the brainstem sections now. Let's talk about the brainstem sections. So here, let me start. At the level of superior colliculus, which is the most important brainstem section, at the level of superior colliculus. So at the level of superior colliculus, if you are cutting, okay, this is a brainstem section at the level of superior colliculus. So here you will see obviously the superior colliculus, and here you will see your cerebral aqueduct, that is the aqueduct of iter, cerebral aqueduct. Here you will see the mesencephalic nucleus, Edinger-Weisspal nucleus, and the nucleus of third nerve. Mesencephalic, Edinger-Weisspal, and the nucleus of third nerve. Can you correlate here? This is your section 1. This is the section. You have taken this one. They have taken this one. So you can see your Edinger-Weisspal. You can see your third nerve nucleus, and as you can see your mesencephalic nucleus, that is of your trigeminal nerve. Okay. So you can now correlate these things. Okay. Then all the lemniscus are present. The spinal lemniscus, trigeminal lemniscus, medial lemniscus. Okay. Lateral lemniscus is not seen here. Lateral lemniscus is being not seen. This is the substantia nigra that is present, and from this third nerve nucleus, your third nerve is originating, cranial nerve 3 are originating. Okay, and here you have the DTD. DTD is the dorsal tegmental decussation. We talked about that in the midbrain level. There is a dorsal tegmental decussation, the ventral tegmental decussation. So these are present here. Okay, and the red nucleus are present here. We have a decussation, that is ventral tegmental decussation, right? And here was a decussation like with dorsal tegmental decussation. And here this is the pyramidal tract. This is the area for the pyramidal tract, and in the cerebral peduncle, this part there will be fibers from your parieto-pontine fibers, temporopontine fibers, and your occipito-pontine fibers. This purple part, and this blue part will be the fibers or frontopontine fibers, only the frontopontine fibers. Okay, frontopontine fibers. And in this frontopontine fibers also, your upper motor neuron of your 7th nerve is also hiding. Your upper motor neuron for the 7th nerve is also hiding in between this frontopontine fibers. Okay, so this is a level at the level of superior colliculus. Let me discuss at the level of inferior colliculus what changes you will see. So here we will have your inferior colliculus. Inferior colliculus is present like this. Okay, and in this part you will see obviously your cerebral aqueduct will be visible, and your mesencephalic nucleus will only be visible. Your Edinger-Weisspal will not be visible as the former case. Okay, and the 4th nerve nucleus, you can see 4th nerve nucleus. The 4th nerve will come and will cross at this point. The 4th nerve will come and cross at this point. Okay, at this level. Okay, 4th nerve will come and cross at this level, and the 4th nerve of this level also. Okay, 4th nerve. Then we'll see here the lateral lemniscus also. Lateral lemniscus will also be seen. The spinal lemniscus, trigeminal, and medial lemniscus as usual. And then here you will see your tectospinal tract being present, tectospinal tract, and your retrospinal tract being present, retrospinal tract and your tectospinal tract. Okay, this tracts you can see. Of course, there will be other fibers which I discussed earlier. Pyramidal tract. Okay, pyramidal tract in this region. Then your frontopontine fibers in these two parts, and your parieto-pontine, temporopontine, occipito-pontine in this part, and also in this part. Okay, so that if you're confused how the mesencephalic and the 4th nucleus are seen, you can just again go back to the table. This is the section 2. We have taken the section 2 at this level. So at this level, what are the 4th nucleus? The 4th nerve nucleus is present. Okay, your Edinger-Weisspal nucleus remained at this upper part. Okay, at this level there will be no Edinger-Weisspal nucleus, so you can't see it. And the 4th, your trigeminal nerve nucleus, again this part will listen the mesencephalic nucleus you will again find, and no other nuclei. Okay, no other nuclei. After this, let's discuss the midbrain syndromes. So we have two syndromes: Weber's syndrome and your Benedict syndrome. Benedict syndrome generally affects this part. Just very carefully do this shape. Okay, very carefully do this shape. SL, TL, ML, and this third nerve. It affects your third nerve. So what are the, if medial lemniscus is affected, there will be contralateral loss of conscious proprioception, touch, pressure, and stereognosis. Okay, the medial lemniscus is affected. Remember the dorsal column medial lemniscal pathway. Of course, there will be contralateral loss. Okay, and if this trigeminal this lemniscus affected trigeminal lemniscus, there will be contralateral loss of pain and temperature from the face. Contralateral loss of pain and temperature from the face due to defect in your trigeminal lemniscus. We'll discuss about the trigeminal lemniscus when we'll discuss. Okay, we'll discuss a bit. And the medial lemniscus, this spinal lemniscus is left. Spinal lemniscus will cause contralateral loss of pain and temperature from the body, right? The trigeminal lemniscus is for your face, contralateral loss of pain and temperature from face, and this is causing contralateral loss of pain and temperature from body. And the third nerve is also affected. Third nerve is also affected. Third nerve is not decussating. Third nerve is not decussating. So there will be ipsilateral. All will be ipsilateral. Okay. So third nerve supplies your levator palpebrae superioris, your medial rectus, your sphincter pupillae, and your ciliaris. Okay, these are being supplied by the third nerve. Remember, the Edinger-Westphal nucleus was in fact giving the innervation to your using the third nerve. Using the third nerve, it was like supplying this ciliaris and your sphincter pupillae, and the third nerve itself was being supplying the medial rectus, right? Medial rectus, and you just remember the mnemonic SRLO, your what was the mnemonic? Your SO4 and your LR6, SO4 and your LR6. Except this, all are supplied, all rectuses are supplied by the third nerve. Okay, so this was the fact. So which four muscles are affected? Your LPS. So there will be ipsilateral ptosis. This levator palpebrae superioris was to elevate the eyelid. So there will be drooping of eyelid, ipsilateral drooping, ptosis. Medial rectus, due to this, there will be ipsilateral divergent squint. The squint will be diverted like this, ipsilateral divergent squint. Due to the sphincter pupillae, there will be ipsilateral dilated pupil and loss of light reflex. Loss of light reflex, and due to loss of ciliaris, due to damage to ciliaris, there will be ipsilateral loss of accommodation reflex. Sphincter pupillae has the light reflex, and ciliaris has the function of your accommodation reflex. So these are the features. These are your features. These are all your features of your Benedict syndrome. It can be easily framed into a clinical case question and be asked before you. Okay. Let's talk about the Weber syndrome. This part is affected here. The pyramidal tract is affected, which will lead to contralateral hemiplegia. Okay, this frontopontine fibers are affected, and due to this affection, I told that the upper motor neuron of seventh nerve is lying beside it, lying behind it. Okay, so there will be your seventh nerve palsy also. Seventh nerve palsy will also occur. Okay. So what will be the effects of this Weber syndrome? Weber syndrome, let's discuss this. So there will be third nerve affected. Of course, the third nerve will also be affected. You can easily involve this third nerve. Third nerve is affected. So there will be same effects, right? Discussed earlier. The pyramidal tract is affected, which will lead to contralateral hemiplegia, and UMN, upper motor neuron lesion of your seventh nerve will lead to contralateral paralysis of lower half of your face. So there is upper motor neuron of your seventh nerve which is hiding. So I told that in upper motor neuron lesion, if there is lesion, the upper motor neuron lesion is there. Okay, this lower half of it, if there is the right upper motor neuron lesion, if there is left upper motor neuron lesion, this is your face, this is your face. Okay, if there is the left upper motor neuron lesion, the right lower half of the face will be affected. But if there is lower motor neuron lesion, element lesion, okay, left element lesion, so there will be same ipsilateral affection, ipsilateral paralysis of this part of face, which is called as your Bell's palsy. Okay, we discussed this in a facial nerve. You can go and check. Okay, so we are done with your midbrain syndromes and midbrain sections, and you can also see this syndrome. Okay, Northanger and Claudius syndrome are not in your course level, so I am not discussing. Let's discuss the transverse section of upper part of pons. So if you just cut the pons like this, and so the shape will be like this, somewhat like this. This is the shape. Okay, just practice these diagrams, very important. If you don't practice the diagrams, you have to of course the diagrams are often asked, and if you just practice the diagram, you can easily correlate the syndrome. Okay, you can easily see what parts are affected, and then draw and check. Okay, and easily solve your clinical case questions. Okay, so here in the level of at the level of the pons, we have your superior cerebral peduncle. These are your superior cerebral peduncle. Okay, superior cerebral peduncle, and your fourth ventricle is present over here. Okay, fourth ventricle is present over here. Your middle cerebral peduncle. Okay, middle cerebral peduncle. These are present, and the inferior are not seen. You have the tectospinal tract and the rubrospinal tract, which is also present over here. Tectospinal, rubrospinal tracts are also present. We have a body which is called the trapezoid body. Okay, trapezoid body is present. Trapezoid body. we'll see what is the function of trapezoid body when we'll discuss on the things, auditory pathway and all. Okay, the lemniscus are present in this manner, in the horizontal manner: lateral lemniscus, spinal lemniscus, trigeminal lemniscus, and medial lemniscus, in this sequence. Okay, in this sequence. And we have the nucleus for the fifth nerve. With the nucleus for the fifth nerve nucleus will be coming like this. Fifth nerve nucleus will be coming like this. Okay, this is the section of upper part of the pons, right? And we have the pyramidal tract also present. Pyramidal tract is also present here, and these are some distributed pontine nuclei. Pontine nuclei just distributed like this. Pontine nuclei just distributed like this. Okay, so if you just correlate with the table, okay, this you can see pons at the upper part of pons. We are taking the upper part of pons. Okay, the upper part of pons means the part which is connecting on midbrain and the pons. Midbrain and the pons, this part, this section we are taking. We are taking this section, So what things we will see? We will only see your fifth nerve nucleus. Okay, nothing else. So talking about this, let's move on. Yes. So that's about your transverse section at the upper part of pons. And talking about the transverse section, lower part of pons, the shape changes at the level of facial colliculus. The shape changes. This is the lower part of the pons, which is taken. So you'll see your ICP here. Okay, your SCP won't be seen now. Your inferior cerebral peduncle and the middle cerebral peduncle you can only observe. Okay, and this is in the shape of in this shape it is there. And here you will not see any colliculi or somewhat like your superior colliculus and all. Okay, you won't see. Okay, this was the superior colliculus, right? Yes, is cerebral peduncle. No, it's cerebral peduncle, right? Okay. Then in this part you will see the eighth nerve being originating, the eighth nerve nucleus, which will be originating from here. Okay, then the spinal nucleus of fifth nerve, you will see the spinal nucleus of fifth nerve. Remember the section, there's the GSA column in which we had the big nucleus of your trigeminal nerve shaped in this manner. Okay, so this lower part will be seen here. Then we'll see 6, 7 and 8 nerves. So 6 nerve will come just like this, crossing our pyramidal tract. 6 nerve will come just like this, and the seventh nerve will go and will go like this and come forward. Okay, again it will cross the sixth nerve and will come like this, and eighth nerve will be originating from more lateral sides. Okay, and the spinal nucleus of fifth nerve will also be seen. Your tectospinal tract, rubrospinal tract are also seen. Or the lemnisci are starting to be absent, like only your trigeminal and medial lemniscus, these only are present. Okay, and the trapezoid body is now stretched. Okay, trapezoid body is the shape of a trapezoid, right? So here we saw only in upper pons we saw only a small part, but in lower part there will be a wide part, and the pyramidal tract is also universally present, and the pontine nuclei are distributed. Let's talk about the pontine syndrome. So the pontocerebellar angle syndrome and a Millard-Gubler syndrome. The pontocerebellar angle syndrome, the Millard-Gubler syndrome. Okay, so talking about this, if this part is affected, this pontine angle is affected. This ICP, MCP, these are affected. Okay, your 8th nerve is affected, and some part of your 7th nerve is also affected. The 7th nerve, your 8th nerve, ICP and MCP, these are affected. So talking about the pontocerebellar angle syndrome, or it is called the acoustic neuroma. So 7th nerve is affected, of course. 7th nerve damage will lead to your ipsilateral facial paralysis. This is the which neuron? Lower motor neuron, of course. Okay, ipsilateral facial paralysis. And 8th nerve damage will lead to your ipsilateral progressive deafness, because 8th nerve is the auditory nerve, right? And there will be ipsilateral progressive deafness. And MCP or ICP, this is affected. Your MCP, middle cerebral peduncle, inferior cerebral peduncle, which will lead to ataxia. Okay, and cerebellum, what is the function of cerebellum? Of course, a balance. Okay, so there will be ipsilateral ataxia, loss of coordination. So I hope you understood a pontocerebellar angle syndrome. Let's discuss your Millard-Gubler syndrome. This part is affected in the Millard-Gubler syndrome. In this Millard-Gubler syndrome, what will be affected? Your 6th nerve is affected. Your 6th nerve is coming like this. So 6th nerve is affected and the 7th nerve is affected. Okay, 2 nerves. sixth nerve and the seventh nerve. Of course, the pyramidal tract is also affected. Sixth nerve, abducens nerve. What is the function of abducens nerve? Abduction. So there will be ipsilateral convergent squint. Okay, if these are your eyes, the squint will be like this, ipsilateral convergent squint. Okay, if both nerves are damaged, if there is a damage to the right part, the right Miller-Guebler syndrome, right part of pons, so there will be only deviation. The convergent squint will only be present in your right eye ipsilaterally. Okay, Miller-Guebler syndrome is also called the abducent alternating hemiplegia. Okay, so that's why seventh nerve is affected, so there will be ipsilateral facial paralysis, obviously pyramidal tract, contralateral hemiplegia as usual. So there will be abducent alternating hemiplegia, Miller-Guebler syndrome. Done. So this is all about the transverse sectioning, and let's now discuss the transverse section at the medulla oblongata level. Okay, we discussed the transverse section at the midbrain and the pontine levels. I hope you understood them very well. Let's discuss the transverse section of medulla oblongata at the level of olive, at the level of sensory decussation, and at the level of pyramidal decussation. Okay, so taking 1A, that is at the level of olive, at the level of a sensory decussation. Okay, at the level of sensory decussation, and basically at the level of your pyramidal decussation. Okay, let's take at the section of medulla at the level of pyramidal decussation first. Okay, we are taking the C section first. So talking about this, we'll see this part. So what are the things? So here what you will see, first of all, you will be able to observe your nucleuses. Okay, the spinal nucleus of 10th, your fifth nerve will also be seen. Your dorsal spinocortical tract. Okay, that DSCT, the spinocerebellar tract, is not cortical. Okay, yes, let's talk about the tracts. So there is a detached anterior horn. Okay, detached anterior horn. Then we have the ventral spinocerebellar tract, present over here. Ventral spinocerebellar tract, the dorsal spinocerebellar tract, which is present over here, ventral and the dorsal spinocerebellar tract, and here we will have the lateral spinothalamic tract. Okay, there will be pyramidal decussation present at this level. Pyramidal decussation like this. You will have a nucleus gracilis and nucleus cuneatus like this. This will be the nucleus gracilis. This will be your nucleus cuneatus. Okay, and a fasciculus gracilis and a fasciculus cuneatus you will also see. And here you will also see the spinal nucleus of your fifth nerve, which is not yet detached. Okay, so these all are being like connected. Okay, these all are like connected here. Then let's take a section of medulla at the level of sensory decussation. What are the things at the level of sensory decussation? So here the shape will be like changed. Here the shape is like just like an apple with some notches in the front. Okay, apple with notches in the front at the level of sensory decussation. So what you will observe, you will these all things which are combined, this will be detached now. These are detached now. Okay, these are detached now. So here what you will see, you will see your ACN is the accessory cunate nucleus. You will see accessory cunate nucleus in these parts. Okay, nucleus cuneatus, nucleus gracilis, fasciculus gracilis, and the fasciculus cuneatus. These parts, fasciculus gracilis and the fasciculus cuneatus. You will see a spiral nucleus. You see a spiral nucleus of fifth nerve. Okay, and you will also see your nucleus of tractus solitarius, your dorsal nerve of vagus, and your 12th nerve nuclei. Remember, we have a table with us. Okay, so we are taking at the level of your sensory decussation. So we are gonna see your nucleus ambiguus, your 12th nerve, and your dorsal nucleus of vagus. Okay, dorsal nucleus of vagus. So these are the parts, nucleus, this part, and this part we are seeing. Okay, these are the parts. Talking about this. Okay, let's go back where it came from. Yes, and you can show the decussation here. This is the dorsal nucleus of vagus being present here, and we have the nucleus of tractus solitarius that is present, and the 12th nerve nucleus that is present, and I have the medial lemniscus. Okay, medial lemniscus. These are decussating like this, going to fasciculus gracilis. The fibers are going to fasciculus cuneatus and fasciculus gracilis, and from this we have to going to the fasciculus, nucleus gracilis and then nucleus cuneatus. So both sides of this decussation, sensory decussation is there. So there is the level of a sensory decussation, at the level of a sensory decussation. Understood? And we have the pyramids here. So if you understood what are the things which are tailing, these are the internal arcuate fibers, these are which are decussating, just a name. Okay. And from here you have fasciculus cuneatus, fasciculus gracilis, nucleus cuneatus, right? Done. So just if I just give you another again a gross overview what we saw just. Okay, you will draw something like this, you will draw your pyramids like this, okay, and just draw something like this. These are all your fasciculus. Okay, this from this your fasciculus will continue, right? So you can name this fasciculus cuneatus, fasciculus gracilis. You can make four things like this. Okay, 4 nuclei, that is your nucleus cuneatus, nucleus gracilis, and your nucleus gracilis and your nucleus cuneatus, right? Nucleus cuneatus. Okay, nucleus cuneatus. So this was being made. And we have a spinal nucleus here, we have the spiral nucleus here, and here also spiral nucleus. The anterior ACT, that is your ACT was what? ACT is a accessory cuneate nucleus. Okay, ACT or ACN you can say. And there will be decussation points, like there will be the medial lemniscus will be present here, medial lemniscus. The decussating fibers, how they will decussate? Will that from the medial lemniscus, the fasciculus cuneatus, fasciculus gracilis, they are going. And from here also they are decussating like this. Okay, this is the medial lemniscus, and this is called the point of your sensory decussation, right? Understood? And these are all your internal arcuate fibers. These are your pyramids. Very simple. Let's discuss the transverse section of medulla oblongata at the level of olive. We will see the nucleus ambiguous and the medial lemniscus also. Okay, so this will be the structure in which we will discuss about the medullary syndromes also. Medullary syndromes are somewhat important. Okay, this is the structure, butterfly shaped structure. Okay, so the transverse section of medulla oblongata at the level of olive. We have this type of section. But what we have, just see, we have our ICP, that is your inferior cerebellar peduncle. Okay, we have olive, and we have our pyramids. Okay, your ICP is there, olive is there, pyramid is there. Can you just correlate with the structure which you had drawn? Okay, and your 12th nerve nucleus, your 12th nerve nucleus will come from here and will give rise to your 12th nerve from here. Okay, 12th nerve from here. Then what nucleus we have? We have the spinal nucleus, 5th nerve, which is like still continuing up to this level. Okay, and your nucleus of tractus solitarius, your dorsal nucleus of vagus, and your nucleus ambiguous, dorsal nucleus of vagus, NTS, and spinal nucleus. These are present in this arrangement. This arrangement is generally new to neurobiotaxis and different movements. Okay, this nucleus is moving at different movements. Okay, and here the tectospinal tract and rubrospinal tract will appear again. Your medial lemniscus is present at this level, okay, and the nucleus ambiguous as I told. And from this nucleus of tractus solitarius, from this dorsal nucleus of vagus, and from this nucleus ambiguous, the 10th nerve is arising. 10th nerve, that is the vagus nerve, is arising. Okay, vagus nerve is arising. And here you have inferior olivary nucleus and the inferior olivary nucleus, that is also present. Okay, and this medial lemniscus, as I told, your pyramid, and the arcuate nuclei are present over the pyramid. This is the displaced pontine nuclei. The pontine nuclei, remember, in the pons we had pontine nuclei in this part, which are displaced to form your arcuate nuclei. Remember? Okay, done. Okay, and this arcuate nuclei will decussate at this superior point, at this upper point, and will give a stria medullaris. So stria medullaris you can very well appreciate in that structure we had drawn of the pons. Okay, this is stria medullaris, giving a stria medullaris. Okay, so basically here the arrangement of the nuclei, it is important. So if I just give you a brief overview, if you just ask me to draw, how I will draw, I will just draw a type of butterfly shaped structure I will make. Okay, and I will do like this, butterfly shaped structure I will make. Okay, and then I'll divide it, form a tectospinal tract and rubrospinal tract. It's easy things. And then we'll be making the nucleus of a 12th nerve, the 12th nerve nucleus, XII and the XII. Okay, 12th nerve nucleus. Okay, I will be making like this, and this is your ICP. This will be your ICP, inferior cerebral peduncle, ICP. And I will draw a inferior salivary nucleus. This is the inferior salivary nucleus, ISN, inferior salivary nucleus. And then what I will draw a medial lemniscus here, MLML, medial lemniscus near the midline. Yes, I'll be making the pyramids, the pyramid and the arcuate nuclei which are arranged above the pyramid like this, arranged across the pyramid like this. Okay, and the most important part is this arrangement here, So you have first your spinal nucleus, starting from here to the spinal nucleus, S, your spinal nucleus, and then you have the nucleus of NTS, that is nucleus of tractus solitarius. Okay, then you have the dorsal nucleus of vagus, and your nucleus ambiguous. Understood? So you can just remember the mnemonic from this in this manner. Okay, you can remember send, 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 ambiguity, like the send ambiguity in your question paper. Okay, so as they're making a question paper, they will put some ambiguous questions which don't have a definite answer. So they're sending your ambiguity, in the ambiguous questions. So S is the spinal nucleus of fifth nerve, N is your NTS, that is your nucleus of tractus solitarius. Okay, D is your dorsal nucleus of vagus, and A is your nucleus ambiguous, right? Ambiguity means nucleus ambiguous. So you can very well remember and arise from this the NTS, the nucleus of tractus solitarius, the dorsal nucleus of vagus, and nucleus ambiguous. These are giving rise to your 10th nerve. Okay, so I have covered all the things which are required for your medulla. Okay, this is the structure of the medulla. Syndromes of medulla oblongata. What are the syndromes of medulla oblongata? So we have this part affected, this all parts are affected. Nucleus ambiguous is affected, ICP is affected, NTS is affected, spinal nucleus is affected, spinal lemniscus is affected. Okay, all these parts are affected. So it's called the Wallenberg syndrome. And if this part is affected, only this part, this medial lemniscus was there and your 12th nerve is there, it's called the Dejerine syndrome. So Wallenberg syndrome and Dejerine syndrome. In medial medullary syndrome is called the Dejerine syndrome, in which the medial lemniscus is affected. So there will be contralateral loss of conscious proprioception. Okay, medial lemniscus, will be contralateral loss of conscious proprioception. Understood? Contralateral loss of conscious proprioception. Of course, you know about this dorsal column medial lemniscal pathway, and you can easily understood what is the contralateral loss of conscious proprioception, touch, pressure, fine touch, all that things. Okay. Then 12th nerve is also affected, right? 12th nerve is also affected, this one. Your 12th nerve is also affected, and due to this affection 12th nerve, there will be ipsilateral loss paralysis. Ipsilateral loss paralysis. Okay, 12th nerve ipsilateral loss paralysis. Okay. And due to the pyramidal tract was there, right? The pyramids were there. So the pyramidal tract was there, pyramidal tract was affected, and due to this affection pyramidal tract, there will be contralateral hemiplegia, right? So ipsilateral paralysis and ipsilateral loss paralysis and contralateral hemiplegia is unique to medial medullary syndrome. Let's discuss the lateral medullary syndrome, that's called the Wallenberg syndrome. Talking about the Wallenberg syndrome here, many things are affected. So if we talk about this, the nucleus ambiguous is affected, so there will be ipsilateral bulbar paralysis. Remember we talked about when we were saying that 12th nerve and the nucleus ambiguous, if these are affected, there will be loss bulbar paralysis, and due to nucleus ambiguous, there will be due to damage to the 10th and 11th nerve, there will be gag reflex loss. So there is no gag reflex loss. Okay, there will be only nucleus ambiguous. So there will be ipsilateral bulbar paralysis. Just ICP or ipsilateral ataxia, obviously. NTS is affected, NTS nucleus tractus solitarius. There will be loss of taste sensations, ipsilateral loss of taste sensations. And due to spinal nucleus, ipsilateral loss of pain and temperature from the face. And due to spinal lemniscus, there will be spinal lemniscus that is present here. So there will be contralateral loss of pain and temperature from the body. So this is unique here. While in Wallenberg syndrome, this is unique. Ipsilateral loss of pain and temperature from face and contralateral loss of pain and temperature from body is unique for a Wallenberg syndrome. So when the syndrome is near midline, no matter if it's pons, medulla or midbrain, the pyramidal tract is affected severely. Okay, near in midline, any midline syndrome, there will be affection of your pyramidal tract. Okay. And in this syndromes, in this Weber's, Millard Goblet and the medial medullary syndrome, okay, contralateral hemiplegia is common. Contralateral hemiplegia is common. Okay, so if you get a patient with contralateral hemiplegia, so you must have a differential diagnosis that the patient may be suffering from Weber's, or the patient suffering from Millard Goblet, or the patient suffering from medial medullary syndrome, that is your Dejerin syndrome, right? WMD, you can remember this, WMD. And how we can differentiate between this? If there is Weber syndrome, ipsilateral third nerve palsy will be there. There is Millard Goblet syndrome in the pons, Millard Goblet syndrome, there will be ipsilateral 7th nerve palsy. And there is medial medullary syndrome, there will be ipsilateral 12th nerve palsy. So if you can just judge by these things, okay, we know the effects, what are the palsy effects, okay. So using these things we can judge which syndrome is the patient suffering from. Okay, so you can easily judge a contralateral hemiplegic patient of which syndrome he is suffering from, if he is suffering from any pontine or medullary syndrome. So that completes the brainstem sections, which is very important. I explained you very logically, very easily, very clearly. Let's now move on to the next part. Let's discuss a bit about the auditory pathway. Your auditory pathway is there. So we have a medial geniculate body and a lateral geniculate body. Medial geniculate body, M for music, M for medial. So it is useful for the auditory pathway. Lateral geniculate body, L for lateral, L for light. So it is useful for a visual pathway. MGB is involved in auditory and LGB is for light, visual pathway. So here we have the medial geniculate body and the lateral geniculate body. Okay, and the lateral geniculate body is connected to a superior colliculus by a superior brachium, and this medial geniculate body is connected to an inferior colliculus by your inferior brachium. These brachiums are white matter bundles. Talking about what are the things, so we have at least 4 order of neurons in the auditory pathway. At least 4 order of neurons. It is the 4th order pathway. As I told you, it is the 4th order pathway. Okay, generally we have the pathways extending to 3rd order, but it is the 4th order pathway. So we have the impulses from your inner hair cells, 95%, from inner hair cell, or outer hair cell 5% only. So these impulses are coming via the spiral ganglion. Okay, it is present in the wall of cochlea. Wall of cochlea has a spiral ganglion. Notice the impulses are coming here, and it's relaying into the cochlear nucleus, which is present at the pontomedullary junction. Remember, pontomedullary junction is this type of vestibulocochlear nucleus, where we had this type of vestibular nucleus and 2 cochlear nucleus are present like this. Yes, remember? Yes. So cochlear nucleus, so pontomedullary junction, then which will relay at this cochlear nucleus. There will be decussation, and I told that decussating point will be again a 2nd order neuron. This is a 2nd order neuron which is crossing a trapezoid body, at the level of trapezoid body. Like this part is a 2nd order neuron. So there is a trapezoid body present and relaying into a superior olivary nucleus, which is present in the pons. Remember, superior olivary nucleus is present in the pons, and the superior olivary nucleus, this again it goes, the 3rd order neuron arises from the superior olivary nucleus. This go via the lateral lemniscus. To the IC. What is IC? Your inferior colliculus. And from this inferior, by moving to the inferior brachium, this reach your medial geniculate body, and this medial geniculate body will give again the 4th order neurons, that will be the auditory radiations to the auditory cortex, broadband areas 41 and 42. Okay, so this is all about your auditory pathway. Let's move on to the next part. Let's talk about the trigeminothalamic pathway, where the BPL and BPM nucleus, I told BPL is the ventroposterior lateral nucleus, BPM is the ventroposterior medial nucleus. They are taking pain sensitive from lower part, that is below mouth, and BPM from mouth and face, right? So what is the whole pathway? Let's see. We have the V1 nerve arising from here, the V1 ganglion, fifth ganglion, that's the trigeminal ganglion we have discussed, right, in the head and neck. So V1 nerve is there. V1 nerve is your which nerve? V1 nerve is your ophthalmic nerve. V2 nerve is your maxillary nerve. V3 nerve is the mandibular nerve. This is relaying the 5th ganglion. This 5th ganglion is going and it's giving in the 5th nucleus. Okay, it's supplying the 5th nucleus. So it is relaying the 5th nucleus from the 5th nucleus. In fact, okay, it is giving the sensory branches to the fifth nucleus. So giving the midbrain, pons and the medulla, midbrain, pons and the medulla. So we know it is a GVA column, so general afferent, general visceral afferent. So there are visceral sensations like pain and temperature, visceral sensations from the general viscera. Okay, and it is afferent, not efferent. So it is not giving sensation, it is acquiring sensations. So this from the nucleus, this parts. Okay, and from this your efferents will arise. Efferents will travel by which lemniscus? Efferent will travel by the trigeminal lemniscus. Okay, so there is decussation at this level, and they will travel by the trigeminal lemniscus, and traveling by the trigeminal lemniscus, these are a second order neuron at the level of decussation. The second order neuron will go to the thalamus. Which nucleus? VPM nucleus, VPM, because it mouth and face, VPM. Okay, and thalamic radiations will be your third order neurons, which will go to a sensory cortex, that is your 3, 1 and 2, right? So this is your trigeminal lemniscus, and this is your trigeminothalamic pathway. Okay, talking about the summary of the lemniscuses. Okay, with the lateral lemniscus, spinal lemniscus, trigeminal lemniscus, and medial lemniscus. So lateral lemniscus, if there is any defect, there will be contralateral hearing loss, okay, because just try to correlate the auditory pathway is involving the lateral lemniscus. If there is a defect to the spinal lemniscus means which part? So spinal lemniscus is carrying the pain and temperature in the body, right? So there will be contralateral loss of pain and temperature from the body, right? And the trigeminal lemniscus we discussed now, it is carrying the carrying the sensations from the face. So there will be contralateral loss of pain and temperature from the face. And this is your medial lemniscus. So there will be contralateral loss of conscious proprioception, touch, pressure, vibration, stereognosis in the medial lemniscus. Remember the dorsal column, medial lemniscal pathway. So these are all the lemniscus, and what are the injuries? Okay, so that completes the trigeminothalamic pathway and the summary of the lemniscuses. Let's now move on to our next part. Let's talk about a cerebellum, very interesting topic, cerebellum. And this is a dorsal view of the cerebellum, that is a superior view, dorsal view or a superior view. This is superior view. The vermis is there, and the two lateral lobes are there. Floccular nodular lobe is there. This is a ventral view, that is a inferior view. Okay, we'll see by drawing. Okay, this is part. So this is a cerebellum, this whole part is a cerebellum. And we have the anterior lobe, this is the anterior lobe, this is yellow side, this is a posterior lobe, is this part, posterior lobe. And we have a flocculonodular lobe. Okay, this is a nodule, and these are two flocculi, flocculonodular lobe. Okay, so you can have a horizontal fissure here. Horizontal fissure is that it is divided like this, 1, 2, 3, 4, and again 1, 2 and 3. Okay, this parts. So what are the parts of the vermis? And how it is connected to the cerebellar hemisphere? Okay, what are the part of the vermis and how it is connected to the cerebellar hemisphere? It is not much important, but you can just remember. Okay, so you can just remember this sequence, and then you can correlate this. Okay, so you can just remember this part. You can just remember this by a mnemonic, that is alok SST fail due to inferiority, this one. So alok SST failed boards due to inferiority. Okay, so alok AL is a ala is connected to the central lobule. This is a central lobule and it's connected to the ala. Okay, CL AL. And afterwards you have O is nothing, 0, and Q is a alok. Okay, Q pronunciation there. So Q is the quadrate lobe which is connected to the culmen. C is the culmen, and Q is the quadrate lobe. So CQL. Okay, CLAL, CQL. Okay, and then you have a declive is there, which is connected to a simple lobe, SL. Okay, SL from SST you have the SL. Okay, that's a simple lobe, and declive is connected to a simple lobe. Then of the F is connected to SSL. So is folium, fun PT, you can remember fun PT. So folium, F is folium, it is connected to superior semilunar lobule from SST, superior semilunar lobule, F, superior semilunar lobule. Okay, so folium is connected to superior semilunar lobule. U is the uvula, which is connected to the tonsil. Uvula is connected to the tonsil. This uvula part is connected to the tonsil. Okay, uvula part is connected to the tonsil. Okay, UT. and then you can remember your nodule is connected to the F, that is flocculus. So floccular nodular loop, so nodule, this is nodule and it's connected to the flocculus, and P is the pyramid which is connected to the biventral lobule. P is the pyramid which is connected to the biventral lobule, BL. Okay, biventral lobule, BL. Okay, failed boats due to inferiority. I is the inferior semilunar lobe that is connected to the tuber is connecting to the inferior semilunar lobe. T is the tuber which is connecting to the inferior semilunar lobe, right? So this is the whole trick. This is, you can say, but this is not important, not much asked. The parts, the micro parts are there. Now the classification of the cerebellum is archicerebellum. Okay, archicerebellum is the vestibular cerebellum. Paleo-cerebellum is the spinal cerebellum. Neo-cerebellum is the cerebral cerebellum. Okay, archicerebellum is the oldest part, contains the lingula, nodule, and the flocculus. This lingula, okay, which part? This one. This lingula, and it contains a nodule and contains a flocculus. So this is the part of a archicerebellum, and this maintains your equilibrium of the body. And paleo-cerebellum is spinal cerebellum, which is next to appear, and it contains the anterior lobe, pyramid, and the uvula of the posterior lobe. Anterior lobe, pyramid, and the uvula of the posterior lobe contains the crude movement of the limbs. And neocerebellum most recent, that is containing a posterior lobe except your pyramid and uvula. So paleo-cerebellum has generally anterior lobe, pyramid, and the uvula. So this anterior lobe, okay, anterior lobe, pyramid, and the uvula also. Okay, pyramid and the uvula. So this whole part, this green shaded part, what I shaded now in green, is considered as a the spinocerebellum, like paleo-cerebellum, sorry. And neocerebellum considers the posterior lobe except the pyramid and the uvula is doing a smooth execution of voluntary movement with precision. After that, let's discuss about the superior cerebral peduncles, middle cerebral peduncles, and inferior cerebral peduncles, and how they are arranged, the cerebral cortex, about the cerebral cortex. So from the outside to inside, we have the molecular layer, the Purkinje layer, and the granular layer. For example, this is the molecular layer, from outside to inside. Okay, this is the molecular layer, this is the Purkinje layer, and this is the granular layer. Granular layer has two types of cells, the Golgi cells and the granule cells. And Purkinje cells, these are present in the Purkinje layers, of course, but these are extending up to your molecular layer as well as your granular layer, right? And we have the basket cells and the stellate cells which are present in the molecular layer. Molecular layer is basket cells, stellate cells. Purkinje layer is Purkinje cells, and your Golgi cells and granule cells present in your glandular layer. Understood? So what are the excitatory cells, which are the inhibitory cells? So we have the stellate cells inhibitory, basket cells inhibitory, Purkinje inhibitory, Golgi cells are also inhibitory, granule cell is the only excitable cell. Okay, and the cerebral cortex is the largest collection of your inhibitory neurons. Okay, so Purkinje cells are the largest cells, only efferent from cortex, and terminate at deep cerebellar nuclei. What are the deep cerebellar nuclei? We have the dentate nucleus, emboliform nucleus, fastigial nucleus, and globose nucleus, DEFG. Dentate nucleus is called the crumbled paper-like nucleus, the largest nucleus and only nucleus of neocerebellum. Emboliform nucleus and fastigial nucleus and the globose nucleus, these are a paleo-cerebellum. And this fastigial nucleus, it is also called the nucleus of archicerebellum. It is also the nucleus of archicerebellum. Okay. And emboliform nucleus plus globose, this emboliform and globose, if you just combine this emboliform and globose, you will get your interpositus nucleus, interpositus or interpositus nuclei. So we have this present medial to lateral side, from medial to lateral side. Okay, you can just remember like this, from lateral to medial, we have a DEFG. Okay, this globose and emboliform, these are present nearby, so they combine, this emboliform and globose combine to form your interpositus, right? And that completes your nuclei. You can see the real-time structure also. What I said is exactly what it is given. Okay, you have read about the neuronal circuitry of the cerebellum if you have read your neurophysiology. So neuronal circuitry of the cerebellum, in which nuclei was inhibiting which nuclei and what was the neuronal circuit. Okay, you have read. Talking about the afferent fibers, we have the climbing fibers and the mossy fibers. Afferent, climbing, and the mossy. So climbing fibers and mossy fibers, what are they? So this climbing fiber, and these are coming from your olivocerebellar tract. and the para-olivocerebellar tract. Okay, these climbing fibers come from olivocerebellar and para-olivocerebellar, and these are extending upwards and giving a feedback to your, giving a positive feedback, in fact positive feedback to your Purkinje cell, right? And these mossy fibers, these are the fibers which are present in this granule cell, which is giving an feedback to the granule cell, which are not directly causing any effect to the Purkinje cell, which are giving a feedback to the granule cell first, and this granule cell again goes and gives a feedback to the that Purkinje cell, right? And the mossy fiber, where the point at which they fuse, is called the cerebellar glomeruli, and there is a rosette type of structure formed. So which are mossy fibers? Mossy fibers originate from all of them which are coming to the cerebellum, like a dorsal spinocerebellar tract, your pontocerebellar tract, your ventral spinocerebellar tract, many other. Okay, let's discuss about comparator function cerebellar peduncles and which tracts are going where. You can just see this things. Okay, talking about this, we have the dentate nucleus. This dentate nucleus, from this dentate nucleus we have the dentitothalamic tract and the dentatorubrothalamic tract. Dentitothalamic and the dentatorubrothalamic tract, which are this dentitothalamic tract is going to the thalamus, as dentatorubrothalamic tract is going to the red nucleus and again to the thalamus, right? And your BSCT, it is your ventral spinocerebellar tract. We talked about the ventral spinocerebellar tract, right? It was coming from down and it was first decussating and coming from down and going like this, right? Then we have from a descending tract from the cerebellar cortex, from the cerebral cortex, we have descending tract. This one is called the corticopontocerebellar tract. Okay, corticopontocerebellar tract. Another one is coming from ACN. ACN is the accessory cunate nucleus, that is called the cuniocerebellar tract. Remember, the cuniocerebellar tract was a replacement of your DSCT. DSCT was a dorsal spinocerebellar tract. Okay, so a dorsal spinocerebellar tract is absent in your upper limbs. So it is the cuniocerebellar tract is the replacement of this DSCT in your upper limb, right? So these are your things which are going inside and coming out. So basically this both dentatorubrothalamic and dentitothalamic are coming out. The BSCT is going inside, corticopontocerebellar is going inside the middle cerebral peduncle, and inferior cerebral peduncle, the cuniocerebellar going inside, and your DSCT going inside. Okay. So there are no efferents of the middle cerebral peduncle, no efferents, only afferents are there. You can just observe only afferents are there of this middle cerebral peduncle. Let's discuss the inferior cerebral peduncle. So what happens is, majorly we have drawn the section at the medulla level. Okay, drawn the section at the medulla level. If you have drawn the section, you have the para-olivary nucleus here present and the inferior olivary nucleus present. So from the para-olivary nucleus, you have from para-olivary nucleus you have a efferent. From para-olivary nucleus you have a efferent, which is going out of this inferior cerebral peduncle. Inferior cerebral peduncle. This is called the para-olivocerebellar tract. And from the inferior olivary nucleus, there is a tract which is going outside. That is called the that is your olivocerebellar tract. The vestigial nucleus, vestibulocerebellar tract. Okay. From the red nucleus, we have from red nucleus, what do we have? From the cerebelloreticular tract. Okay. And from the ACN, which tract was coming? Your cuniocerebellar. So it is also an efferent. Okay, it is also an efferent. So ACN, this is your ACN, and the efferent is your cuniocerebellar tract. This is purple one. Okay. From the DSCT again, which is called as the dorsal spinocerebellar tract. Okay. And from this arcuate nucleus, we have your anterior external arcuate fibers, which are also going through this inferior cerebral peduncle. Okay, understood? So these are your tracts. Which are there. So what are the afferents? What are the efferents? So what are the afferents of this inferior cerebellar peduncle? This inferior cerebellar peduncle is majorly important. Okay, this we haven't shown many of this because the diagram will be messy. Okay, we have discussed this both. So very easy. The superior cerebellar peduncle, this is receiving the afferents are received by the VSCT, and the efferents, two efferents. We have the red nucleus, that is the dentitothalamic tract and the dentitorubrothalamic tract. and this middle one only has one efferent, only one efferent, that is the corticopontocerebellar tract. Okay, one efferent, corticopontocerebellar tract. And talking about the efferents and afferents, we have efferents, that is the vestibulocerebellar tract. Okay, vestibulocerebellar tract. Efferent is the cerebellovestibular tract. Just the reverse. Olivary tract afferent, cerebello-olivary tract efferent. Para-olivary tract is the afferent, cerebello-para-olivary tract is the efferent. Reticulocerebellar afferent, okay, and the cerebello-reticular is the efferent, okay, is the efferent. So you can easily you can do this. Okay, from the vestibular nucleus, the vestibulocerebellar, and for example, vestibulocerebellar, right? It's the afferent, and it's the afferent, okay, and efferent is the cerebellovestibular, right? You can easily do this. Clinical anatomy, we have to discuss the clinical anatomy. Cerebellar lesions, these are there. So what are the features? Truncal ataxia will occur, that is the unsteady posture in the gait. Nystagmus is the horizontal nystagmus. Eyeball starts vibrating on side gaze. Eyeball start vibrating. Dysmetria is the inability to estimate or measure distances. Intentional tremors will occur, that is tremors on asking the subject to do some fine movement like picking up a pen, touching the nose. There will be intentional tremors. Like on doing movement, there will be tremors, and there will be no resting tremors. There will be intentional tremors. Dysdiadochokinesia, that is no alternating movement will occur. Like alternating movement means we will ask the patient to clap or repeat syllables. Okay, like da da da. Ask the patient to do this, or you can ask the patient to clap. Alternatively clap. Like first clap the palmar aspect of the hand, then clap on the dorsal aspect of the hand. Okay, and the patient with the cerebellar ataxia will tend to clap on the dorsal aspect repeatedly or the palmar aspect repeatedly. Okay, he can't do the alternating movement properly. Dysarthria is a slurred speech. Okay, broken speech or slurred speech. And rebound phenomenon is present, like the patient can't stop any jerk movements. If you ask, if you just pull the hand of the patient, just ask the patient to make the hand steady and don't move the hand. Ask the patient to pull the hand towards his side, but you pull towards your side. Okay, then if you leave the hand, the normal man would just stop his hand at this point so as to avoid hitting, but the patient with cerebellar ataxia will hit, okay, himself. Okay, this is called as rebound phenomena. This is called as Stewart Holmes rebound phenomena. Flexion of the forearm against resistance, sudden release. Normal reaction is the prompt control. Abnormal reaction is the dysmetria, that is striking the head. Okay, and you can just diagnose this dysdiadochokinesia by this. Done. So after this, we are now discussing the next topics of this chapter. Okay, let's move on to the next topics. Let's discuss our very important part, that is cerebrum. Cerebrum is the center of intellect. Okay, it is mainly involved with the intellectual functions, the emotions and all. So cerebral cortex is the gray matter. Cerebral cortex is the gray matter part. What are the surfaces of the cerebral cortex? So a superior lateral surface, a medial surface, and an inferior surface, right? And the borders, we have superior medial border, superciliary border, inferior lateral border, inferior medial border, medial orbital border, and medial occipital border. Okay, so what are the this is a superior medial border, this is a medial surface, right? And this is the orbital surface, this is the orbital surface, this is the tentorial surface, orbital surface, tentorial surface is there. Okay, and talking about this, we have the inferior borders. About the borders, we have the superciliary border, and medial orbital border. This is the medial orbital border. The inferior surfaces are there. The inferior surface, this is the inferior surface, this is the inferior surface. Okay, this both are inferior surfaces. And your inferior lateral border is there, your hippocampal border is there, this is the hippocampal border, and a medial occipital border. Gyri and sulci, this is the gyri are present, and sulci is the depression. Gyrus is the projection, sulci is the depression, and the gyrus, which is larger in size, is called as a lobule. This larger gyrus is called as a lobule. Gyri and sulci increase with age. Like if you just take out the brain of a older person, then he will have many gyri and sulci as compared to a brain of a child. Talking about the superior lateral surface, we are talking about the superior lateral surface now. This was the superior medial surface. This is a medial surface, right? We are talking about the superior lateral surface. This one, superior lateral surface. So let's talk about this, how it will appear just here. This is a superior medial surface. The superior lateral surface. So what will be the parts? That first we have some sulcus and gyrus. Okay, some sulcus mainly. So we have the superior frontal sulcus here, superior frontal sulcus, the inferior frontal sulcus. Okay, we have another sulcus, that is a precentral sulcus, your central sulcus, that is called the Rolandic sulcus, your post-central sulcus. And here we have the precentral gyri. Between precentral sulcus and the central sulcus, we have the precentral gyri and the post-central gyri, right? And this one, above the superior frontal sulcus, the superior frontal gyri, middle frontal gyri, and the inferior frontal gyri, right? And here we have the interparietal sulcus, which divides into superior parietal lobule and inferior parietal lobule. And then we have parieto-occipital sulcus here, parieto-occipital sulcus here, which is dividing it into this part. This part is forming, and this is a lunate sulcus, this is a lunate sulcus, and this is a calcarine sulcus, lunate sulcus and a calcarine sulcus. And then in this part also, in this lobe also, we have this temporal lobe, we have the superior temporal sulcus, the inferior temporal sulcus. Okay, and this is a sylvian sulcus. Sylvian sulcus is posterior limb of a lateral sulcus. Okay, posterior limb of a lateral sulcus. This is your sylvian sulcus, and this is forming the superior temporal gyri, the middle temporal gyri, and your inferior temporal gyri, right? And here we have the lateral sulcus, which is there, the anterior horizontal limb of the lateral sulcus, this one. The ascending limb of the lateral sulcus is this one, ascending limb, just dividing into A, B, and C part. And posterior limb is your sylvian sulcus itself. Okay, so this type of arrangement is there of the lateral sulcus, right? A, B, and C, what are the parts present in the inferior frontal gyrus? This is your inferior frontal gyrus. And what are the parts A, B, and C? So A is the pars opercularis, B is the pars triangularis, and C is the pars orbitalis. Opercularis, triangularis, and orbitalis. Opercularis, triangularis, and orbitalis, right? Opercularis, triangularis, and orbitalis. So these are the parts. Talking about this is just your real-time diagram. What are the sulcus and what are the things? Okay, which I just drew in a very simplified manner. And this diagram you can just correlate. I have labeled this also. You can just take a screenshot and read. Done. Okay, let's move ahead. Let's talk about the medial surface. This is the medial surface. We talked about superior lateral surface. Now we have to discuss the medial surface. So this is the whole medial surface of this. You will see a corpus callosum here. Okay, and like this. This is your medial surface. And this is the anterior part. This is your posterior part. So what are the things present here? We have a central sulcus. Central sulcus was the sulcus that was nothing in the superior lateral part, superior lateral surface. It was prominent. Okay, here only a little bit of central sulcus there. Then a sulcus which is very prominent here is the cingulate sulcus, and this part is this is your cingulate sulcus. This is a cingulate sulcus. Then we have a supraspleneal sulcus. Because the corpus callosum has a splenium part. This is a splenium part of the corpus callosum, splenium part. We'll see about the parts of corpus callosum. So the sulcus that is present above is called a supraspleneal sulcus because it is present above the splenium. And this is forming a cingulate gyrus. Just below the cingulate sulcus we have the cingulate gyrus present. And we have the PCL. What is PCL? Your paracentral lobule. PCL. This PCL is the highest center for micturition and defecation. This PCL is helpful for your micturition and defecation. And here we have the supraspleneal sulcus, which is forming your PC. What is your PC? Your PC is the precuneus. Okay, a region called as precuneus. And we have a parieto-occipital sulcus, which is forming a C. What is C? C is a cuneus. It was a PC is a precuneus, C is the cuneus. Okay. And here the calcarine sulcus is again present. We have a corpus callosum. Corpus callosum is present. Then in this temporal lobe, we have the things like your rhinal sulcus. This is called a rhinal sulcus. This is a collateral sulcus, collateral sulcus, and the occipitotemporal sulcus. This is a rhinal sulcus. Okay, which is dividing the parahippocampal gyrus and your uncus. Uncus is present here. Uncus. Remember uncus? Uncus was forming the lateral boundary of a cavernous sinus. If you have read cavernous sinus in head and neck, just you can correlate. And here we have the collateral sulcus passing like this, and occipitotemporal sulcus passing like this. MTOG and LTOG segments are formed. What is MTOG? MTOG is a medial temporo-occipital gyrus. LTOG is lateral temporo-occipital gyrus. Okay, lateral temporo-occipital gyrus and medial temporo-occipital gyrus. So these are all your features of your medial surface. Okay, medial surface. So you can just see in the diagram also I have labeled. Take a screenshot. Yes. Let's see the inferior surface. So we are done with the superior lateral surface, the medial surface. Let's move on to the inferior surface. And what are the gyrus and sulci that are present, we'll see. So first of all, we have our part, which is this part. Okay, we are seeing only one lobe. So we have the olfactory tract that is present on olfactory sulcus. Okay, olfactory tract is present, and here is the orbital sulcus, a H-shaped orbital sulcus present. Okay, this orbital sulcus is H-shaped. Have I written somewhere? No, not written. No problem. We have a H-shaped orbital sulcus. Okay, H-shaped orbital sulcus, which is forming A, M, P, and L. What is A? A is the anterior, so anterior orbital gyrus. M is a medial, so medial orbital gyrus. L is the lateral, so lateral orbital gyrus. P is the posterior gyrus, right? We have a rectus gyrus also, this is called rectus gyrus. Okay, and this part is divided into three sulcus. The three sulcus are present. Okay, we have the PHG, that is a parahippocampal gyrus, MTOG and LTOG, the same one. This was the uncus. So this part is visible over here also. Okay, so the rhinal sulcus, the collateral sulcus, the occipitotemporal sulcus. Okay, the rhinal sulcus, this is a rhinal sulcus. This must be your occipitofrontal sulcus, this one. Okay, this occipitofrontal sulcus, this one. This occipitotemporal sulcus, this one. Occipitofrontal, not occipitofrontal, it is occipitotemporal, right? I told wrong maybe. And collateral sulcus. So here we have these three sulcus. Okay, you can just try to label this. You can, if it is confusing, this is your rhinal sulcus. This is a callosal sulcus. Right? Okay. Sulcus, and this is your occipitotemporal sulcus. Understood? These are visible in that diagram also. Understood? So here also it is labeled, you can see. Done? Okay. Let's talk about the areas now. So in superior lateral surface, you have the Brodmann's classification. Okay. So what areas you have? This one is the which was this part? The central sulcus is there. So this must be your post central gyrus, right? You have read about central sulcus, so it must be a post central gyrus. This is a pre-central gyrus. The post central gyrus is a Brodmann's area 1, 3, 1 and 2 are present, which are called the primary sensory cortex. This is the primary sensory cortex. Then we have the 5 and 7 that are present in this. Which lobule is that? This is a superior parietal lobule, SPG, superior parietal SPL. So superior parietal lobule 5 and 7 is present. It is called the sensory association area. Okay, this is a sensory association area. Like storing for previous experiences, storage, stereognosis, memory, etc. Then we have 4, the area 4 that is present on a pre-central gyrus. It is the primary motor area, origin of the pyramidal tract. Remember, pyramidal tract is originating from the motor cortex, 4th part, right? We discussed today. So this is the 4th part, and this 4th part is we can say that the central sulcus is separating the motor and the sensory parts of your brain. Okay, you can say that. 6th part, let's discuss the 6th part here. This is a triangular 6th part, and this 6th part is causing, and this 6th part is present in the posterior part of SFG, MFG and IFG, that is the inferior, superior, and this is the superior frontal gyrus. Okay, and in middle frontal gyrus and the inferior frontal gyrus, so it is present in the posterior parts of this. Okay, posterior part of this, and this is called the premotor area. This is called the premotor area. This is the premotor area. So what we have our primary sensory cortex, okay. Then your sensory association areas, your premotor area, your primary motor area, right? Primary motor area. Sorry, your fourth one is the primary motor area, and sixth one is the premotor area, right? Premotor area, which is the origin of extrapyramidal tracts. All the extrapyramidal tracts originate from the primary motor area, right? Sorry, your premotor area. And eighth one is present on the middle frontal gyrus, and also on the medial frontal gyrus. Also on the medial frontal, this one, the middle frontal gyrus, and also on the medial frontal gyrus, right? So it is the frontal eye field area. Eighth one is the frontal eye field area, which is causing scanning movement of the eyeball. Scanning movement of eyeball independent of the visual stimuli. It is causing a frontal eye field area. This one is causing a scanning movement of the eyeball independent of the visual stimuli. And 44, 45, it's important. 44, 45, this one. You know this one is pars opercularis. This, and 45 is the pars triangularis, right? So 44 is the pars opercularis, and 45 is present in the pars triangularis. These are present in inferior frontal gyrus, and these are in motor speech area, that is a Broca's area. Okay, 44, 45, Broca's area, very important. This Broca's area you must have read in physiology, that it is causing a motor aphasia, and there is a Wernicke's area also, which is causing a sensory aphasia. This is 22 to 29 that present. Okay, 22. Let's say 22, 39, and 40. These are Wernicke's areas. Then we have the 41, 42, that is the primary auditory area, Hell's cortex, 41 and 42. Let's see the 41, 42 here. Just pay attention to this part. In your superior temporal gyrus, you have this semilunar part, and 41, 42 is present deep to this. So it's 41, 42 is present. It's called as primary auditory area, that is Hell's cortex. Okay, and 22 is the auditory association area. You can just say this 22 is there. So primary auditory area, and 22 is the auditory association area. So 22 is the auditory association area. It's a component of your Wernicke's area. As in the superior temporal gyrus only stores the memory of the speech. Okay, and 39 and 40, where they are present, you can see 39 and 40 here and here. Okay, so it is present in the this one is the which sulcus is Sylvian sulcus, right? The Sylvian sulcus, it is 40 is present the edge of the Sylvian sulcus, and the superior temporal sulcus. Okay, so edge of the superior temporal sulcus contains your 39. So 39 is present in the angular gyrus. Okay, angular gyrus you can say, and 40 is present in the supramarginal gyrus, right? Angular and supramarginal, that synonymous terms. There are sensory speech areas, interpretation of language. So 39, 40 and 22, these are your Wernicke's area. 39, 40 and 22. So 22, 39 and 40 comprise of Wernicke's area. Injury will lead to sensory aphasia. Not able to understand what someone is saying. And sensory aphasia and motor aphasia makes the global aphasia. Okay, in like middle cerebral artery stroke, there is global aphasia. And 17 is the primary visual area. 17 here it is seen in the calcarine, the area surrounding the calcarine sulcus is the primary visual area. Okay, 17 is the primary visual area, and 18 and 19 are the visual association areas here. 18 is like this, and 19 is like this. Okay, these are your prime association areas. Okay, 18 and 19 are your association areas of visual association areas. Okay, so let's learn about the insula now. It is also a lobe of your cerebrum, okay, which is not seen, it is present deeply. So let's see about the insula and what are the gyrus and the sulcus which are present in the insula also. Okay, then we'll go to the sensory and the motor homunculus. Okay, so talking about the insula, it is called the island of Reil. The central lobe of the cerebrum. If you just take out the parietal operculum, like reflect the parietal operculum, that is the front of parietal operculum, and reflect the lateral sulcus, the lateral sulcus is opened up and it will expose the hidden lobe of the cerebrum, that is your insula. And what are the gyri and sulci? You have three gyri brevia. These three are called as the gyri brevia. And there's two parts. Just you can consider one part. This is called as the gyri longa, gyri brevia and gyri longa. Okay, so the temporal operculum, the frontal operculum, is this one, and your parietal operculum is this one. So basically what we have done, we have just opened up the lateral sulcus. Okay, lateral sulcus has three parts, like parietal operculum, okay, your then frontal operculum, temporal operculum, these are parts. Okay, and there is a limen insulae present over here. Let's talk about the sensory and motor homunculus now. So sensory homunculus, we have what are the things that are like which parts of brain are being like what that contribution is there to the homunculus. Okay, so homunculus is basically representative diagram, discussing about the homunculus, we have this part of the brain, this part of the cerebral cortex. So here we have the foot, the leg, trunk, the head is there, very little contribution of the head. Okay, you can get the arm and a hand, very big representation of hand, and face also has a very big representation. Nose, especially the lips, have very big representation, and then your tongue, pharynx and larynx. This part is supplied by the anterior cerebral artery. Anterior cerebral artery is supplying this part, this whole part up to half of your up to your arm, right? From the forearm part up to your tongue, larynx and pharynx, these are being supplied by your middle cerebral artery. So you can see the homunculus, the sensory homunculus. You can see the hands have very big representation, the legs, the foot have very big representation, and in face we have the cheeks and the mouth, that is tongue and lips. These have very big representations. Okay, and rest have very small representations. Talking about the sensory homunculus, this is your sensory homunculus. You can see the things. Okay, after that let's discuss the white matter of the cerebrum. Okay, let's discuss the white matter of the cerebrum. White matter of the cerebrum is basically a long question. Okay, it comes as a long question sometimes. So discussing about the white matter, we have the association fibers, the commissural fibers and the projection fibers. Three fibers: association, commissural, projection. Okay, association fibers connect different areas of the same cerebral hemisphere. Commissural fibers are basically connecting same areas of both cerebral hemispheres, and projection fibers are connecting the cerebrum to the lower part of the cerebrum, right? Projection fiber basically this connecting gray matter and the white matter of the cerebrum. Okay, association fibers are connecting the same different areas of same cerebral hemispheres. Okay, different areas of the same cerebral hemisphere, like one cerebral hemisphere is that let's discuss. Okay, here, so association fibers are connecting these 2 points, you can say. Okay, and commissural fibers are connecting these 2 points, and projection fibers connecting cerebrum to some other point. Okay, some other point. Understood? Done? Understood? So this is all about your association fibers, and we are gonna discuss this association fiber in great detail. So association fibers, let's talk about the association fibers first, then go to commissural, then go to projection fibers. Association fibers, so these are intrahemispheric fibers. We have 2 types: the short association fibers, that is connecting adjacent gyri are the short association fibers, right? Or short association fibers which are forming arcuate fasciculus, and long association fibers, this connect distant gyri. Like we have your superior longitudinal fasciculus, fronto-occipital fasciculus, inferior longitudinal fasciculus, cingulum, and uncinate fasciculus, this 5. Okay, so you can just see how they are connecting. So this one we're like focusing at the medial surface of the brain. This one is the cingulum. Okay, which is called the limbic association fiber. Then we have the fronto-occipital fasciculus, like fronto-occipital fasciculus. Then the superior longitudinal fasciculus, like the superior longitudinal fasciculus. Then the inferior longitudinal fasciculus, like this inferior longitudinal fasciculus. Okay, understood? So we have our corona radiata in this form. So the superior longitudinal fasciculus is lying just posterior to it, and your fronto-occipital fasciculus is just lying like here. Okay, so all this fasciculus. And there is an uncinate fasciculus also, which is not senior. Yes, it is senior, you can see. So uncinate fasciculus is there. Uncinate fasciculus is basically connecting your Broca's area 44-45 with the sensory speech area, that is your 39-40, and your auditory association area, that is your 22. Okay, so this is basically connecting your Broca's area to the sensory speech area. Okay, and if there is damage to the uncinate fasciculus, it will cause a conduction aphasia. This uncinate fasciculus is also called, if you learn physiology, it is given in a Ganong textbook that uncinate fasciculus is also called as your arcuate fasciculus. So arcuate fasciculus is basically the projection fiber, the white matter bundle which is connecting your Broca's area to the vernix area. It connects important areas, that is Broca's area, auditory association and sensory speech. This auditory association plus your sensory speech area, this both are basically forming your vernix area. Okay, vernix area, and vernix area, you know the Brodmann's area 22, 39 and 40, 22, 39 and 40. Understood? And the injury will be called as conduction aphasia. That is, the person can speak and read but cannot repeat words. Okay, if he hears words, he cannot repeat them. Then let's talk about commissural fibers now. So these are your interhemispheric fibers that are connecting same areas of the different hemispheres. Like your corpus callosum is there, anterior commissure, posterior commissure, habenular commissure and the hippocampal commissure. So the 5 commissural fibers. Okay, so areas having no commissural fibers are there, like a visual cortex and sensory area of hand, Okay, these have no commissural fibers. Let's talk about corpus callosum. Corpus callosum is the largest commissural fiber. It is very important, largest commissural fiber. Length is 10 cm, 200 million fibers are there in it. What are the parts? We have 4 parts: rostrum, genu, body and the splenium. We talked about the splenium, right, where the supraspleneal sulcus was present. So the rostrum, genu, body or splenium, RGBS. Okay, red, green, blue, you can remember like this. So if there is the corpus callosum, this is the corpus callosum. So basically we have the rostrum part. This is the rostrum part. Okay, this is the rostrum part. And this is a genu, that is the turn part, and the B is the body, it's a large part, body is a large part, and S is the splenium, which is the largest, which is the widest part, basically most dilated part, right? And here we have the fornix, and here we have the anterior commissure as well as your posterior commissure present. In the superior lamina, pineal gland and inferior lamina. So we have a pineal gland has 2 lamina, that is superior and inferior. So in superior lamina and inferior lamina, in the inferior lamina of the pineal gland, our posterior commissure is present, and in the superior lamina of the pineal gland we have the habenular commissure that is present. Okay, habenular commissure is present. And here we have SP is the septum pellucidum. Septum pellucidum means transparent. Okay, septum pellucidum. And the rostral part, at the rostrum we have our anterior commissure that is present. Okay, so we discussed how the corpus callosum is extending, and anterior commissure and posterior commissure, habenular commissure. We discussed all this. Okay. Basically these are showing this corpus callosum in lateral ventricle and septum pellucidum, how it is extending. This septum pellucidum is extending like this, the septum pellucidum. Okay, and it is separating the 2 lateral ventricles on the both sides. Okay, septum pellucidum basically separating the 2 lateral ventricles on the both sides. You can see the superior lamina, which is having a this is a superior lamina. You can just focus here. The superior lamina here, which have your habenular commissure. This is the pineal gland, and this is the inferior lamina like this. You can focus on the structure. Okay, this part, focus on this part. So I have the superior lamina having the habenular commissure and inferior lamina having the posterior commissure, right? Okay, anterior commissure connects olfactory bulb, olfactory tubercle and amygdaloid body. What it connects? Olfactory bulb, olfactory tubercle and your amygdaloid body. Habenular commissure, it connects your habenular nuclei both sides. Hippocampal commissure connects both fornix. So both fornix are connected by hippocampal commissure. And posterior commissure is connecting your Edinger-Westphal nucleus, superior colliculus and pretectal nuclei both sides. Edinger-Westphal, superior colliculi and the pretectal nuclei both sides. Okay, so it's basically posterior commissure is basically connecting your superior colliculi. Okay, it's basically connecting your superior colliculi, Edinger-Westphal nucleus and your pretectal nucleus. It is connected by a posterior commissure. What are the relations of the corpus callosum? The corpus callosum relations are also important. Okay, and we'll also see about the modification of the corpus callosum. Modifications are also important. We'll discuss about the internal capsule and what are the fibers in the internal capsule. Then we'll discuss about some disorders. Okay, so a good chunk of things to remain to discover. This is the corpus callosum. So basically what is happening that we have the indusium griseum, like that granular material is the indusium griseum. We have this anterior cerebral artery which is forming the anterior relation, and we have the medial and lateral longitudinal stria. We have the medial and lateral longitudinal stria that is also forming your superior relation. Anterior cerebral artery, medial and lateral longitudinal stria, the indusium griseum, this is forming superior relations, and inferior relation is formed by the septum pellucidum, the fornix, septum pellucidum, and the lateral ventricle. Fornix, septum pellucidum, lateral ventricle, these are forming the inferior relations. Let's talk about the modification of corpus callosum. So we have the corpus callosum, which is this is a genu part. This is genu part of the corpus callosum. This is splenium part of the corpus callosum. So from the genu part, there are modifications called the forceps minor fiber. Forceps minor fibers. These are forceps minor fibers. Okay, which connect the anterior part of the frontal lobe. This is connecting the anterior part of the frontal lobe. Okay, and then we have here we have tapetum fiber. Tapetum fibers are there. These are the tapetum fibers from the splenium part, which arise from the splenium and sweep backward. They sweep backward and run medial to posterior horn of lateral ventricle. So basically this is the lateral ventricle that is present here, and the posterior horn, this tapetum fiber passing lateral to the posterior horn of this lateral ventricle. Okay, so these are passing medial to the posterior horn of lateral ventricle. Okay, tapetum fibers are basically passing lateral. Okay, tapetum fibers are basically passing lateral to this, and your forceps major fibers, these are forceps major fibers. These are passing medial. These are also arising from a splenium, sweeping backward and running medial to the posterior horn of lateral ventricle. Okay, so these are your posterior forceps major fibers. Forceps minor fibers are there. Forceps major fibers are there in the posterior part, and we have the tapetum fibers, right? Tapetum fibers. And this bulb of the posterior horn of the lateral ventricle, is due to the force it produced due to the forceps major fiber only. And the occipital pole, this occipital pole is basically 6 cm away from the splenium part. So if the 6 cm away, we have the occipital pole. So the forceps major fiber and also the tapetum fibers. These are connecting your occipital poles. They are connecting your occipital poles, right? So you can see the fibers. They are very like not much distinguishable here in this diagram. So this diagram is must. This diagram is a must. You have to remember this diagram. Okay, so forceps minor, forceps major, and tapetal fibers. These are your modifications of your corpus callosum. Let's talk about the projection fibers. So projection fibers, we have the corticofugal fibers and the corticopetal fibers. Corticofugal, corticopetal. Corticofugal fibers are which go away from the cortex, and the corticopetal fibers towards the cortex, like internal capsule, the fimbriae, fornix, and corona radiata. These all are projection fibers. Okay, this is the internal capsule, and this gives your corona radiata. These are your projection fibers, right? So we have to discuss the internal capsule. It is also a very important topic. Internal capsule is also a very important topic. You have to just note what are the things which are there in the internal capsule and what are the parts of the internal capsule. This is also a very important part. Okay, this is also a very important, and you can get easily a short note. Or it can be combined into a long question having it can combine all the fibers, like what are projection fibers, then what are the corticofugal and corticopetal fibers, give example of projection fibers, describe internal capsule briefly. This can be combined into a long question also. Okay, mark my words what I am saying. Basically, internal capsule. Let's discuss the internal capsule. So we have anterior limb, we have a genu, a posterior limb, and a RL. That is a retrolentiform part. R is a retrolentiform part, and a SL. SL is that this is a sublentiform part. Anterior limb, genu, posterior limb, retrolentiform, sublentiform, right? So basically, we have your head of the caudate nucleus, your lentiform nucleus, and your thalamus. You have a thalamus here, you have a lentiform nucleus here, and you have the caudate nucleus, head of the caudate nucleus here. So basically what are the parts? With the anterior limb, genu, posterior limb, retrolentiform part and sublentiform part. Okay, so let's talk about this. These are the fibers of our internal capsule. You can see here. Okay, you can see here. What are the sensory fibers in the internal capsule? Okay, sensory fibers in the internal capsule are called as the thalamocortical fibers. Like, so what are the sensory fibers? So from the thalamus there arise superior thalamic radiations, which are sensory fibers. Then from the thalamus arise anterior thalamic radiations, also sensory fibers, and inferior thalamic radiations or auditory radiations. Okay, auditory from the medial geniculate body, not from the thalamus, from the medial geniculate body there arise auditory radiations, that are your inferior thalamic radiations. These are also sensory fibers. And the lateral geniculate body we are arising posterior thalamic radiations, which are your optic radiations. Okay, optic radiations. So the superior thalamic radiation, or the anterior thalamic radiation, posterior thalamic radiation and inferior thalamic radiations. So these are your thalamocortical fibers present in the internal capsule, right? Then what is the passage for ascending tracts via the internal capsule? What is the passage for the ascending tract? So the anterior thalamic radiations are passing by this, the superior thalamic radiations are passing by the genu and the posterior limb. Optic radiations are passing by this part, which is the retrolentiform part, and the auditory radiations are passing by this sublentiform part, right? So this anterior limb is basically giving rise to superior thalamic radiations, anterior radiations. A for A, you can remember like this, A for A. Okay, and superior thalamic radiation, genu and the posterior limb, and optic radiations is allowed by the retrolentiform part, RL part, and auditory radiations by the sublentiform part, S part. Okay, sublentiform, SL part. Okay, understood? So you can remember the mnemonic ROSA, ROSA. So retrolentiform part is basically allowing optic radiations, and the sublentiform part is basically allowing the auditory radiations. You can remember ROSA, right? And of course, A for A, anterior thalamic, anterior limb. Okay, understood? After that, let's discuss the motor fibers in the internal capsule. So, you have the corticospinal tract, pyramidal tract, the corticonuclear tract or the corticobulbar tract, the corticopontocerebellar tract. Okay, corticopontocerebellar tract. So, this corticopontocerebellar tract has frontopontine fibers, paritopontine fibers, occipitopontine fibers, temporopontine fibers. Remember, we had the fibers. Remember what fibers we had, like if we drew the midbrain section at the level of your superior colliculus, this is superior colliculus, and we had the nuclei for the third nerve and all. The third nerve was going like this. So basically here in this part what we had were three things. We have the pyramidal tract here, and this part was giving a frontopontine fibers are there, and in this part I have stated now, it had your paritopontine, occipitopontine and temporopontine fibers. Remember in the midbrain sections? Yes, we talked about this today only. So what motor fibers are there? We have a corticospinal, okay, corticonuclear and corticopontocerebellar, right? And these fibers are a part of your corticopontocerebellar tract. So which part of internal capsule is allowing which fibers? So this genu part is allowing a corticonuclear tract, and here we have that posterior limb. So posterior limb is allowing your corticorubral tract as well as corticospinal tract, the pyramidal tract, to go through it. Pyramidal tract is going through it. Remember the posterior we wrote in the pyramidal tract. That it is going, when it is going through the internal capsule, the posterior limb of internal capsule, remember we had written there in the pyramidal tract. Okay, you would go back to the notes and see. So corticospinal tract, this is allowing anterior 2/3 of your posterior limb. It is allowing your corticospinal tract to go through it, anterior 2/3. Okay, so if you just get a representation of the body, you can easily do this. Okay, so the this parts will affect this part. Okay, like a corticonuclear tract, if this part is affected, if the genu is affected, then the head and neck will be paralyzed. If the genu is affected, the head and neck will be paralyzed. If your this whole part, this corticospinal tract, the pyramidal tract is affected, there will be hemiplegia, right? So this all parts will be affected. Very easy. Okay. It is very easy. Talking about the CNS disorder, let's talk about CNS disorder. Multiple sclerosis is there, is the most common disorder. Okay, not the most common. There will be multifocal patchy demyelination throughout the white matter, in decreased velocity of impulse transmission, weakness of limbs, and ataxia will occur. So the seizure disorder, epilepsy, episodic sudden violent involuntary contractions of the group of muscles due to excess discharge. Meningitis, inflammation of meninges, encephalitis, inflammation of brain and spinal cord, and herniation of brain. This herniation of brain, we have various levels at which herniation may occur. Herniation may occur through craniotomy defect. There is a craniotomy defect, that if the cranial vault is not properly closed in surgery, then herniation may occur. The cingulate gyrus herniation, the cingulate gyrus that is herniated here, and there is central tentorial herniation, there is lateral temporal herniation, okay, and there is cerebellar tonsil herniation. What is contracoup injury of brain? Contracoup injury, the head is hit suddenly on the back or the front, the brain is displaced in opposite direction and strikes again the cranial bones on that side and get injured. Like there's a dashboard and the person strikes in the dashboard, the brain will like moving in this direction. Okay, the brain will strike this hard part, that is the bones, and will be injured in the posterior part. If so the brain will be injured in the opposite level of injury. The impact is in the level, the injury will be at this part. Okay. The primary impact will be at the front part, and the secondary impact, which is contracoup impact will be in the posterior part. Understood? So that completes the cerebrum. Let's move on to the next part. Now we are basically into the third ventricle. So we have to discuss the third ventricle. Roof is formed in the fornix and the choroid plexus. Okay, the fornix and the choroid plexus is forming the roof of the third ventricle. We have a diagram. If you have a diagram, let me show you. Yes, so basically this is the third ventricle. You can see this is the third ventricle. You can see this is the third ventricle, and this fornix, the fornix and the choroid plexus, you can see the fornix as well as the choroid plexus is present downwards. These are forming a roof. Okay, these are forming a roof. We have the corpus callosum here, the septum pellucidum here, the fornix and the choroid plexus, which are forming the roof. Okay, and here the anterior wall is by anterior commissure, fornix, and the lamina terminalis. Okay, so anterior wall is again formed by the fornix, a part of fornix. Okay, and anterior commissure is told that it is present in the rostral aspect, that is your present near the rostrum of the corpus callosum. So anterior commissure, fornix, and the lamina terminalis. This is called lamina terminalis. Okay, lamina terminalis, which is forming your anterior wall. Fornix, anterior commissure, and lamina terminalis are forming an anterior wall. Understood? And after that we have our posterior wall formed by habenular commissure, pineal gland, posterior commissure, and the aqueduct of Sylvius. Habenular commissure, the pineal gland, your posterior commissure. Just you can remember, like the habenular commissure was present in this part, right? And your posterior commissure was present in this part. Okay, and pineal gland was there, and the aqueduct of Sylvius must be lying there in that part. So the habenular commissure present here, pineal gland present, the posterior commissure is present, and then we have the aqueduct of Sylvius also, is going like this and forming this posterior wall, So we discussed the anterior wall, the posterior wall, the roof. Okay, what we have left? The floor. Let's go to it. Floor is from the optic chiasma, infundibulum, mammillary body, posterior perforating substance, and the tegmentum of the midbrain. So basically you can see here have the optic chiasma, here's the infundibulum of the pituitary gland. Must be lying here. The mammillary body is present here. Okay, the mammillary body is present. The posterior perforating substance is present in this part, and the tegmentum. This is the tegmentum part. This is the tegmentum of the brain. Tegmentum part, which is present. Tegmentum part, which is forming the posterior part. Sorry, the floor of this. Okay, the floor of this. Then what is there? Lateral wall is from the thalamus and the hypothalamus. Lateral wall is from the thalamus. This is thalamus, and this is your hypothalamus. Understood? So that completes your third ventricle. Let's move on to the next part. Now let's come to the lateral ventricle. So we are discussing the lateral ventricle, very important part. It is also. So what are the parts? You can see it has an anterior horn. It has a body and a posterior horn present. Anterior horn, posterior horn, body, and the inferior horn. Okay. And by this interventricular foramen, it is connected to the third ventricle. In the third ventricle, the aqueduct is arising, and this aqueduct is giving rise to a fourth ventricle. Okay, fourth ventricle also. So this in this part, how the ventricles are connecting, you can easily observe. And this is a trigone is there, which is called the collateral trigone, right? So we are basically taking section from one anterior horn, we're taking a section from the body, we are taking a section from the posterior horn, and taking a section from the inferior horn, right? So what are the relations? Relations to the anterior horn. So basically we have this is your anterior horn, which must be present below just the corpus callosum, right? So the body of corpus callosum will be like slashed here. Okay, so body of the corpus callosum will be seen, which is forming the roof of the anterior horn. Okay, and the septum pellucidum, we know that it is extending from the body to the rostrum, right? Body of corpus callosum to the rostrum. There's a septum pellucidum. Septum pellucidum is the medial wall. It will form the medial wall, and the head of the caudate nucleus. The head of the caudate nucleus will form the lateral wall, and the rostrum, the corpus callosum, will form the floor. Rostrum will form the floor, right? It is which section do you know? Your coronal section. And in this plane you have slash, and you are looking from this side. Looking from this side. Can you understand now? So that completes the relation of the anterior horn. Talking about okay. These are your roof, lateral wall, medial wall, floor, and anteriorly it is run by the genu. Anteriorly there will be the genu, right? Let's talk about the relations of the body. So if their bodies is slashed, if the body is slashed, okay, so we will have our ACA, that is the anterior cerebral artery. Anterior cerebral artery will be present. We have the corpus callosum that will be forming the roof. Corpus callosum forming the roof, and septum pellucidum will be there as usual, forming the medial wall, and we will have the fornix also, forming the fornix also. And again your this part is the choroid plexus. Okay, choroid plexus will form, and this whole parts are this is the thalamus, this is the thalamus. The thalamus will be there, and a body of caudate nucleus will be present at this point. Body of caudate nucleus, the stria terminalis, and the thalamostriate vein also. Okay, basically we have new structures that are arising. You can just remember the structures. Okay, you have no time to visualize this. Okay, so basically we have forming the roof is the corpus callosum. Corpus callosum is forming the roof of this. Corpus callosum forming the roof. Septum pellucidum forming the medial wall. Of course, septum will be the medial wall. The body of caudate nucleus, the stria terminalis, thermostriate veins, the thalamostriate veins, thalamus, choroid plexus, fornix. These are forming the floor, right? So this is a relation of the body. Let's talk about the relations of posterior horn. So basically this is a posterior horn, and you have the forceps major fibers present. Forceps major fibers that will be present here. Okay, the optic radiations will be present. The taptum will be present. Taptum. Okay, and there's an axis which is called the calcar axis. Calcar axis. So this is there, and the calcarine sulcus is there. Calcarine sulcus is the calcarine sulcus. So basically this bulb of your posterior horn, the calcar axis, these are forming your medial wall. These are forming a medial wall. And talking about the inferior horn. So this is the inferior horn. This is the inferior horn. So the tail of the caudate nucleus will be there in the roof, which will form the roof of this this one, and forming the floor will be the hippocampus. Okay, this is the hippocampus. Let's take some other color. This is the hippocampus. Okay, and this is a collateral eminence. This is a collateral eminence and a collateral sulcus also. You can write collateral sulcus, but you can just write your hippocampus and collateral eminence, which will form your floor. Okay, hippocampus and collateral eminence will form your floor, and the tail of the caudate nucleus will form the roof. Understood? So that completes your lateral ventricle. Let's move on to the next part. So guys, let's talk about the thalamus now. Thalamus, it is the important relay center of the brain. Important relay center is that. So we have what nucleus is? We have the anterior nucleus of thalamus. Anterior nucleus. We have the lateral nucleus of thalamus. We have the medial nucleus, and two lateral genucleate body and medial genucleate body is connected. This is the axis of the thalamus, which is oblique in nature, and the internal medullary lamina is dividing it. Okay. So basically what we have the anterior thalamic nucleus in this part. Anterior thalamic nucleus. We have medial thalamic nucleus. So we have two parts of medial thalamic nucleus, a medial dorsal and a medial ventral nucleus, right? And of this lateral thalamic nucleus, there are many parts of the lateral thalamic nucleus. So basically we have this lateral dorsal nucleus, lateral posterior nucleus, lateral dorsal nucleus, lateral posterior nucleus. Okay, pulvinar is there, and your ventral. So basically what we have, a ventral side is there. So the ventral anterior nucleus, ventrolateral nucleus, ventral anterior, ventrolateral, and a ventral posterior nucleus, VP, ventral posterior. The ventral posterior lateral, VPL and VPM. This VP is also two parts, VPL and VPM. So basically this is the thalamus. Basically this is the thalamus. And talking about this thalamus is the important relay center of the brain. You know this. Lateral thalamic nuclei, we have the dorsal tire nuclei and the ventral tire nuclei. Okay, so this lateral nucleus has dorsal tire, ventral tire. This in the dorsal tire we have the lateral dorsal, lateral posterior. Okay, lateral dorsal, lateral posterior, and the pulvinar. And in the ventral tire you have your ventral anterior, ventrolateral, ventral posterior, that is VPM and VPL. Okay, this VA, VL, VPM, MGB and LGB, these are your specific thalamic nuclei. These are called as your specific thalamic nuclei. That is this part, this green part. Then observe this whole part. This whole part which is enclosed in the box. This whole part is enclosed in the box. These are called as specific thalamic nuclei. These have connections with the other parts of the brain. Okay. So basically this we have stressed this fact. Okay, this is a VA, VL, VPL and VPM, MGB and your LGB. So what are this? We have a pallidothalamic tract. Okay, that's a globus pallidus. We have a globus pallidus and a putamen and a globus pallidus in a lentiform nucleus. So basically we have a pallidothalamic tract in which the globus pallidus is giving a supply to the VA, and this VA is relaying into the 6th number part. Okay, what is the 6th number part? The 6th number part is your premotor cortex. Okay, premotor cortex. And this dentate nucleus, okay, dentate nucleus going giving to that tracts, that is a dentatothalamic tract and your dentatorobrothalamic tract. We talked about this in cerebellum, yes. So this is a dentatothalamic and this is a dentatorobrothalamic. This is passing to the red nucleus. This is going to the VL, and VL is giving the supply to 4th part. VL is giving the supply to the 4th part. 4th part is the motor cortex, primary motor cortex, right? And this medial lemniscus and the spinal lemniscus, these are supplying, this medial lemniscus and spinal lemniscus, these are supplying to the VPL. And this trigeminal lemniscus, and there is a solitothalamic pathway which is relaying into the VPM. So this VPL and VPM, these both are relaying into your 312. 312 is primary sensory cortex, right? And then we have the lateral lemniscus which will relay. Lateral lemniscus is helpful in the optic radiations. Optic fibers are there. So lateral lemniscus, it will go by the medial geniculate body. Lateral lemniscus is involved in the auditory pathway, right? Auditory pathway. Lateral lemniscus saw in auditory pathway. Okay, and if there is a damage to the lateral lemniscus, there will be a progressive deafness and all. The medial geniculate body to the auditory cortex, that is your 41-42. And this visual pathway is giving to the lateral geniculate body, supplying to the lateral geniculate body. This lateral geniculate body impulse will travel to the visual cortex, that is your 17, 18, 19. 17, 18, 19 is the visual cortex. So that completes your thalamus and connections of the specific thalamic nuclei. This are called the specific thalamic nuclei. So after this, let's move on to the next part of this chapter. Let's talk about the blood supply of the brain. So basically this is the last topic of this chapter. So the vertebral artery, we know about the vertebral artery. The basilar artery is there in the foramen magnum. Okay, you can just do like this. This is the first part of subclavian artery, Okay, so we have basically the branches of this artery, vertebral artery. So we have the first part of vertebral artery, and the second part which is going by the foramen transverse cilium of the C6 to C1 vertebrae, C1 to C6 vertebrae, not the C7, C1 to C6 vertebrae, and then is dividing a basilar artery and other arteries. Okay, the third part, and this is the fourth part. Fourth part is the basilar artery. So basically we have the branches of the vertebral artery. First part is the muscular branches. Okay, first part has the muscular branches. So this is the first part. If this is the first part, it has only muscular branches. Second part has spinal branches. The second part, when it goes to the spinal column, the foramen transverse system, it will give spinal branches, obviously, right? And the fourth part will have muscular branches again. Fourth part will have again muscular branches. The third part will again have muscular branches, and the fourth part has anterior spinal artery, posterior spinal artery, medullary branches, pica, and meningeal branches. Okay, these are the 5 branches. These are 5 branches, like anterior spinal, posterior spinal, medullary branches, pica is the posterior inferior cerebellar artery, and then meningeal branches, Okay, so these are the branches of a fourth part of the vertebral artery, right? Understood? Done. So to remember the branches of the fourth part, you can remember the mnemonic map. Okay, remember the mnemonic map, M-A-P, map. So map stands for which of the arteries, you can see here. So M stands for your meningeal branches. M is for your meningeal branches. As for meningeal branches, A is for anterior spinal artery, anterior spinal artery, and P is for the posterior spinal artery, and your pica, posterior spinal artery and your pica, and M is also for your medullary branches. So medullary branches, meningeal branches, anterior spinal, posterior spinal, and pica. Pica is a posterior inferior cerebellar artery. Let's talk about the basilar artery. So basilar artery, basically what happens is that this is the basilar artery. So we have here in the upper part of the pons, we have the posterior cerebral artery. This is PCA. Okay, it comes down and it gives your superior cerebellar artery. This is a basilar artery. It gives pontine branches here. Okay, it comes down and give branches that are your AICA, that is the anterior inferior cerebellar artery. Your posterior inferior cerebellar artery was a branch of your vertebral artery, but this anterior inferior cerebellar artery is a branch of your basilar artery, right? Basilar artery. And this gives to labyrinthine artery also. This AICA gives labyrinthine artery also, which is the most common, most commonly gives rise to labyrinthine artery, but sometimes basilar artery itself will give you a labyrinthine artery. Okay, and this basilar artery, this comes and divides into two vertebral arteries, right? Then let's talk about the internal carotid artery. So we have four parts of internal carotid artery. There's first is the cervical part, second is the petrous part, third is the cavernous part, and fourth is the cerebral part. Okay, this is extra cavernous. So basically we have cervical part, petrous part, cavernous part, and cerebral part. So let's see. First part is your cervical part, present in your carotid sheath. Remember carotid sheath. Remember your carotid sheath, right? Just say that you remember. Here is the carotid sheath. This is the carotid sheath. We talked about carotid sheath in the head and neck. This carotid sheath, what are the contents of the carotid sheath? The carotid sheath has your internal carotid artery going, then it has your external jugular vein going, and then it had a nerve. Which nerve? It had a nerve, that is a vagus nerve. That was going. Okay, vagus nerve was going. And the wall of the carotid sheath, you had your ansa cervicalis. Ansa cervicalis also present in the wall of this carotid sheath. Okay, so which part of this ICA is going here? It is your cervical part of the ICA. Okay, cervical part. Okay, then we have in the carotid canal region, we have the carotid canal. This is the carotid canal region. We have the carotid part. Okay, we have the second part. There is the petrous part. Okay, petrous part that is present in the carotid canal. So this is the petrous part of the internal carotid artery. Then there is a part which is going where petrous part is going via foramen lacerum. And when it is reaching a cavernous sinus, it is called the cavernous part, present in the cavernous sinus. This is called the cavernous part, where it makes a siphon. Remember, we talked about the cavernous siphon, and this artery, this internal carotid artery, was being seen two times in when we are discussing the relations of the cavernous sinus, carotid siphon. And this fourth part is called the extra cavernous part, that is the cerebral part. Okay, so that's about this artery. And first part has no branches. Second part has bony branches because it's present between bones. It is giving bony branches. And third part has inferior and superior hypophyseal arteries. Third part has inferior and superior hypophyseal arteries, artery to sphenoidal layer sinus, and meningeal branch supplies the wall of the cavernous sinus. So we have inferior and superior hypophyseal artery to sphenoidal layer sinus, and meningeal branch. Okay. And the fourth part has five branches. Your ophthalmic artery, middle cerebral artery, anterior cerebral artery, posterior communicating artery, and anterior choroidal artery. Ophthalmic, middle cerebral, anterior cerebral, posterior communicating, and anterior choroidal artery. Okay. So you can just remember the mnemonics of the fourth part. You can just make a mnemonic like this. These mnemonics are being made by me also at this moment, because this may help to retain a branch if you just forget. So just do revise your mnemonics. Okay. It so happens in exam you remember the mnemonic but you forget the artery. Okay, that should not be gonna happen. You should be able to forget the mnemonic and retain these parts. Okay, forget the mnemonic and retain these parts. But as a memory technique, let me make a mnemonic like oh my amazing, oh my amazing ACP, oh my amazing ACP. Okay, so you have ACP Pradyumn in your CID, and you are you like his personality, so you are taking telling oh my amazing ACP. Okay, oh my amazing ACP. So this O is for your ophthalmic artery, and M is for your middle cerebral artery, MCA, middle cerebral artery. Amazing is for anterior cerebral artery. This A is for your anterior cerebral artery is done. So you have anterior choroidal artery which is left, choroidal artery, anterior choroidal artery, AC and PC also like this. Okay, so you have posterior PC is for posterior communicating artery. So these are the 5 parts of your fourth part. Understood? And this middle cerebral artery is the continuation of your internal carotid artery only. Okay, it continues and the middle cerebral artery. Let's talk about the circle of Willis. Very important topic. Circle of Willis is like people keep on asking this part. Okay, what arteries are contributing to the circle of Willis? How it is formed? Okay, this is all. Then we discuss some arterial supplies and we'll finish up the chapter. Okay, so we have majorly your anterior cerebral artery and the anterior communicating branch here, anterior cerebral artery and the anterior communicating branch. So basically what is happening that this is the internal carotid, this is the internal carotid. Let's take some other color, it's causing confusion. Yes. So here is your internal carotid artery, here is your internal carotid artery. It is giving an anterior communicating artery, anterior cerebral artery, anterior cerebral artery. It is giving your posterior communicating artery, posterior communicating branch, posterior communicating branch, two sides, and a middle cerebral artery. Middle cerebral artery will not be contributing to the circle of Willis. Okay, and we have this anterior cerebral artery. These are connecting to the internal carotid like this, and then we have a anterior communicating artery also, which is connecting to anterior cerebral arteries. Okay, then we have your posterior communicating arteries. So basically these arteries are forming a circle of Willis. Your ACA, your anterior communicating artery, your internal carotid artery, okay, and your posterior communicating arteries. Okay, so anterior communicating, posterior communicating, ACA and ICA, and also by the PCA also PCA is contributing to it. PCA, the posterior cerebral artery. Okay, posterior cerebral artery, and the basilar artery is there. So basically this is circle of Willis. Just practice this diagram. I'll say practice this diagram until it becomes a reflex to draw this. Okay, it has become a reflex for me, like I draw like this. The internal carotid, your MCA, your ACA like this, ACA like this. Okay, then posterior communicating, then I continue its basilar artery. Okay, I then make 2 branches, that is a posterior CA, PCA, and then here we have the anterior communicating branch, posterior communicating, and then we have your anterior choroidal artery, internal carotid, that is ICA, internal carotid, that is contributing to it, internal carotid contributing to it, ACA is contributing to it, and your PA is contributing to it, PCA is contributing to it. So this is a circle of Willis. Done. So that becomes a reflex if you practice the diagram hundreds of times. Okay, just not 100, then metaphorically I told, like you can practice the diagram at least 10 times. Okay, you can easily practice the diagram at least 10 times. Just quickly draw, and you're great to go. You'll never forget. Let's discuss the blood supply of the cerebral hemisphere. So the superior lateral surface, it is supplied to the anterior cerebral artery. Majorly it is supplied to the middle cerebral artery, this part, and posteriorly by the posterior cerebral artery. This middle cerebral artery is running across your sylvian fissure, right? The medial surface is basically supplied by anterior cerebral artery. Major part is supplied to the anterior cerebral artery, and some part is middle cerebral artery. This part back posteriorly middle cerebral artery, and posterior part by posterior cerebral artery. Understood? And inferior surface we are talking about this. Then this part is the middle cerebral artery. This part is the anterior cerebral artery, and this part is the posterior cerebral artery. This posterior cerebral artery must be running along like this. Okay. Let's talk about the blood supply of the internal capsule. So you can, there is a short note on the internal capsule. You can include this part also. You can include this part. So a bit important thing here. It's a berry aneurysm. We'll discuss about that. Okay, let's discuss. So basically, what is happening is that we have the internal carotid artery. Just internal carotid artery is there. Yes. So basically, this is the anterior cerebral artery. This is the anterior cerebral artery. ACA, anterior cerebral artery. Okay, anterior cerebral artery. And this ACA is giving another branch, is the anterior perforating at the level. This artery is given, which is supplying the anterior limb and the genu, which is called the recurrent artery of Hubner. This recurrent artery of Hubner is giving innervation to this anterior limb and your genu part. Okay, and we have your a middle cerebral artery. This is giving two other branches, that is your Charcot's artery, another branch, and your Charcot's artery, another branch, and your Charcot's artery. Another branch is also supplying the genu part. So genu has two blood supplies, you can say, and your Charcot's artery is there. Okay, Charcot's artery is also called the lenticulostriate artery. It's also called the artery of cerebral hemorrhage. So Charcot's artery is basically a branch of your MCA that is supplying your posterior limb. So Charcot's artery is supplying the posterior limb of your internal capsule, and it's called the artery of cerebral hemorrhage. It ruptures most frequently. Then your anterior choroidal artery is coming like this, and is supplying this posterior limb again. Then we have the posterior communicating branch, PCA, posterior communicating branch. And here the PCA is coming. The PCA is gonna supply this from the basilar artery. PCA is a branch of basilar artery, right? Basilar artery. So this PCA is gonna supply your S part and your R part. What is the S part and your R part of internal capsule? So basically we have the sublentiform part and your retrolentiform part. Okay, so the PCA is supplying a sublentiform and the retrolentiform part. Okay, and also supplying the posterior limb. So these are your arterial supply of your internal capsule. You can just practice this diagram. Okay, and talking about clinicals, we have the anterior cerebral arteries is most common site for berry aneurysm. So it can occur here, it can occur here also. Okay, and this anterior choroidal artery is called the artery of cerebral thrombosis. So most common site of hemorrhage, extradural hemorrhage most commonly occurs in your anterior division of middle meningeal artery. Subdural hemorrhage occurs in your bridging veins. Subarachnoid hemorrhage occurs due to rupture of a berry aneurysm. And intracerebral hemorrhage, most common site of intracerebral hemorrhage is your Charcot's artery. That's why it is called the artery of cerebral hemorrhage, right? Venous drainage of the brain is there. Three external cerebral veins are there. Superior cerebral vein, 8 to 12 in number, middle cerebral vein 2 in number, and inferior cerebral vein. So middle cerebral veins we have two, like superficial and deep branches. Okay, we have this superficial superior sagittal sinus is there. You know this superior sagittal sinus, which is giving a superior cerebral veins. Okay, and there is a transverse sinus. And there is a sigmoid sinus. And we have the cavernous sinus here. Okay, and there is a superficial middle cerebral vein. This is a superficial middle cerebral vein. So basically, an anastomosis of Trollard is formed by the superior cervical cerebral veins. Okay, the superior sagittal sinus and your superficial middle cerebral vein. This is connected by anastomosis, which is called the superior anastomosis of Trollard. Okay, and the superficial middle cerebral vein and your transverse sinus. And the transverse sinus is connected by another vein, is called the inferior anastomosis, that is the anastomosis of Labbe. And basically this cavernous sinus and the sigmoid sinus are draining into internal jugular vein, right? Understood? So what are the things which are supplying this? Okay, and another things about the anastomosis, about the Trollard and all. Okay, I have to just write few things. That is your superior sagittal sinus. Okay, SSS, superior sagittal sinus, plus your superficial middle cerebral vein. SSS plus MC, middle cerebral vein. These are forming your anastomosis of Trollard. Okay, Trollard. And your that transverse sinus TS plus your middle cerebral vein. These are forming an anastomosis of labii. You can remember like this TS. T is present. Where T is present, it is not trollad. Where T is present, it is labii. Where T is absent, it is trollad. T absent, it is trollad. Right? This can be a trick. This can be a trick to memorize. Okay. And if we see the inferior surface, we have the inferior surface. Inferior surface is basically this part is drained by the anterior cerebral vein. Okay, this part is drained by the deep middle cerebral vein. Deep middle cerebral vein. This one, this deep middle cerebral vein. This is a superficial middle cerebral vein, but it is deep now. This deep middle cerebral vein. These are draining into the basal vein of Rosenthal. The basal vein of Rosenthal. This basal vein of Rosenthal is draining basically into this great cerebral vein. Great cerebral vein, which is called the vein of Galen. Okay, this is the vein of Galen, and this basal vein of Rosenthal and this great vein of Galen. Okay, these are forming a straight sinus. Okay, in this manner. So that's all about your blood supply of brain. That's all about the blood supply of brain. And here we complete our chapter. That is neuroanatomy. Okay, we completed our chapter neuroanatomy. It was day 6 of anatomy marathon. So we have completed the whole anatomy. You can see the part 1. The part 1 was your lower limb and your upper limb, lower limb. Okay, part 2 we did pelvis. Okay, part 2 we did pelvis, and we had the part 3. Part 3 was probably the abdomen. Okay, part 3 was the abdomen, and part 4 was the thorax. Part 5 was the head and neck, and now is the part 6. Part 6 is the neuroanatomy. Okay, so basically have completed all these chapters in your YouTube, and the complete coverage is there. I can say complete coverage is there. All the clinicals, all the things which are needed for the exam. Okay, so I hope you are enjoying these lectures. So do tell me if you are. Do like, share and subscribe. Okay, I hope you are having a great time ahead. I wish you all the best for your exams. Okay, I have my exams too, so I'll start preparing for that. Okay, so do like, share and subscribe. Do like and do share my lectures, and subscribe to my channel for more educational lectures. You will get each and everything. So here is me signing off. Here is the Metaverse by Biswanath Tripathy, and here we complete our anatomy marathon. So let's say done and dusted. Okay, that's all from my side. Thank you all. Thank you for being such a great audience. Okay, bye bye.